Thanks for the invitation. And can you see my slides?
Yes, your slides can be seen, yeah.
Okay, great. Good morning. And from my time, it's good evening. And anyway, thanks for inviting me to this very important meeting. So today, this is a physiology session. I would like to talk about the resting indices, focusing on comparison between the resting and hyperemic indices. So in the beginning, there was a resting pressure gradient. So this is Dr. Grunzi. So when you first performed the balloon angioplasty, actually he measured the resting pressure gradient using the PA and PD pressure extracted from this large over the balloon catheter. But this wasn't that effective, mainly due to the large over the wire balloon catheter, but it was also due to at that time, there was no concept of hyperemia, so that the intracoronary pressure measurement have been forgotten for almost 15 years. Then the concept of fractional flow reserve or the hyperemic pressure gradient was developed by the Nicopaus and Bernard de Bruyn and Lance Gold, so that they first established this FFR concept in the animal model and then validated in human coronary circulation and comparison with the PET coronary perfusion flow. So since then, we know very well about the successful story of the FFR, and the reason why they applied the hyperemia in the beginning was that according to the Ohm's law, when the resistance is minimal and very stable, pressure flow relationship can be linear. So here is a curve which shows the blood flow and pressure relationship. So this is normal coronary artery, and generally there's no pressure gradient across the normal epicardial coronary artery. But when there's a stenosis there, if the pressure drop occurs by 30%, according to this linear relationship, there is a 30% flow decrease. So this is a fundamental base of the hyperemic pressure difference or fractional flow reserve. And this is from our recent paper, which measured the pressure flow resistance in human coronary circulation. And when the stenosis severity increase, this is a situation of hyperemia, as you might expect it. So there's no difference in resistance because it's already minimal through the hyperemic effect of the adenosine over the necroendial. So that this is minimal, stenosis severity increases, blood flow decrease, and proportionally pressure gradient increase. So this is a fundamental background for the FFR. And you know that there has been several clinical outcome data from registries and this landmark randomized trial, including FAME1 and FAME2 and several other recent large registries support the concept that if there's a big hyperemic pressure ratio or the FFR is low, we can understand that there is ischemia. And if we fix this lesion by revascularization and decrease this hyperemic pressure ratio, we can improve the patient outcome. So that's the success story of the FFR-guided PCI, and that's how the FFR has been a gold standard approach in the cath lab for patients with coronary artery disease, especially intermediate stenosis. Suddenly, there was a return of forgotten resting pressure index, not under the name of resting pressure index, but under the name of the instantaneous wave-free ratio, or the IFR, in 2011 during TCT. You may know already about this concept very well, but just for introduction, IFR represents the PDPA ratio during the resting wave-free ratio, where the resistance is maybe not minimal, but very stable. So during this period, pressure and flow relationship can be proportional. So even without hyperemia, it can estimate the flow reduction during a resting period. So that's the concept of the IFR. And the reason why people like IFR very much is that the IFR doesn't need ischemia, so its measurement is quick and instantaneous. So for this mid-LAD lesion, if I want to measure FFR, I have to setting up the hyperemia and adenosine. So in this case, it took 20 minutes to achieve this stable hyperemia. And you know very well that the adenosine can cause AB block and chest discomfort. But if I just want to measure IFR, like this case, it's taking only 4 seconds. No need of hyperemia, no need of extra drug, extra time, additional complication. So that it's quick and instantaneous, but we need a data and background. So some people argue that how resting pressure gradient can represent the decrease in flow or stenosis severity, because we all know that in the resting condition, flow is very stable unless the stenosis severity is more than 90-95%. But even though flow is stable, as stenosis severity increases, there's changes in microvascular resistance, which transformed into the difference in pressure gradient, so that even in the resting status, if we try to measure flow, it may fail to represent the stenosis severity, but if you simply measure the pressure difference, we can estimate the physiologic stenosis severity even during the resting period. So that's the background of the IFR, and you know very well that there has been 2 large landmark clinical studies which show the non-inferiority of IFR guided approach in comparison with FFR guided approach from Define Flare study and IFR Sweetheart study, and we recently have a 2-year follow-up has a similar outcome. So non-inferiority of this IFR guided revascularization has proven in comparison with the FFR guided strategy. So until several years ago, we had only one hyperemic index in the cath lab, and now we have second one, instantaneous rate-free ratio, different cutoff. So it's acceptable. But we all know that our life in the cath lab isn't that simple. After introduction of this IFR, there has been so many different indices, such as a contrast FFR, cutoff 0.83, QFR 0.8, CT-derived FFR, full cycle resting PDPA, diastolic pressure ratio under the name of DPR, DFR, and RFR. So there are so many numbers here. So in this case, where there is an intermediate stenosis in the mid-LAD and diagonal branch, 5 years ago, the numbers I can achieve is only 2 numbers, LAD FFR and diagonal FFR, but here 0.9, 0.8, 0.85, 76, 89, 74, 77, 66 is the numbers I can measure in the cath lab. And here you can see contrast FFR, LAD diagonal, resting PDPA, IFR, FFR, and if you have a DPR, DFR, and IFR, you can double this number. So the question is how we can handle all these too many numbers in our daily practice. So that's the question. And simply, we now divided the pressure ratios into the FFR versus non-hyperemic pressure ratio. So in the beginning, there was only FFR, and we now have resting PDPA, DPR, DFR, IFR, and RFR. And some are whole cycle pressure ratio, and some are diastolic pressure ratio, and some is instantaneous. So I would like to briefly talk about the RFR because it's unique. So unlike the other invasive physiologic indices, a resting full cycle ratio is the instantaneous PDPA during entire cycle. So it can pick either diastole and systolic period only if it is lowest PDPA. So that's the difference between the RFR and all the other indices. So in the cath lab, all these parameters are available. So the question is, all these variables are the same or the different? So we had a chance to investigate about this topic for several years, and I would like to briefly talk about the messages I learned from this trial. So first thing is that all these are resting indices, and this one is hyperemic indices. So among these resting indices, are these all the same or the different? So here is a correlation plot between RFR, IFR, DPR, IFR, and DPR and RFR. As you can see, there is a very strong correlation among all these resting indices. So I can say that these are all similar in terms of the absolute values and also in terms of relationship between FFR, RFR, FFR relationship, DPR, FFR relationship, IFR and FFR relationship. As you can see, recognize easily, there's a very quite similar relationship. So that in terms of value, I would say that all these resting indices has a same distribution, absolutely, and along with the hyperemic indices. For the diagnostic accuracy, there has been several debates about that, but I would say that the winner can be determined what kind of reference are you using. So here is the study results where we use the PET, a sodium fluoride perfusion PET derived CFR and RFR as a reference. So apologize for this very complicated slide, but if you simply focus on the diagnostic performance or accuracy of the FFR and IFR, if we apply the reference of CFR from PET, IFR is better. But if you apply the RFR, which is more closer to the FFR concept, FFR is better. So that I would say the winner can be determined by the referees. Another interesting idea is that the cutoff. So if you simply review all the stories which can define the cutoff, actually, when we say there's an exercise stress test is positive and myocardial perfusion imaging is positive, we can say there's ischemia, but we know that all these non-invasive tests is the kind of a surrogate of ischemia. And in the early 70s, FFR cutoff 0.75 were derived from all these non-invasive tests. So I can simply say that the FFR is a surrogate of ischemia. And IFR cutoff 0.89 is derived from 0.8 FFR cutoff. So now I can say IFR is the surrogate of ischemia, and DPR, DFR, IFR cutoff was derived from the IFR 0.89. So all these variables has a surrogate of ischemia. So how can we say that those surrogate stories can have any scientific background and also the reliable cutoff? So for that, we analyzed the cutoff of each these resting indices independent of FFR value or the IFR value using the relative perfusion defect and sodium PET, ammonia PET derived CFR. It is very interesting that the cutoff is exactly the same, which derived from the IFR or the FFR reference, so that the relative perfusion defect rest PDPA cutoff 0.9 to IFR 0.9, DPR 0.9, RFR 0.89, which is similar to the current available cutoff, so that I can say that all these cutoff value may have an independent scientific value. And again, I would say that as I shown you earlier, even the resting pressure gradient, either whole cycle or the instantaneous or diastole, can represent the stenosis severity, as it represents the change of the microvascular resistance according to the increase of stenosis severity. But one interesting finding is that if you carefully observe the changes of the resting pressure and hyperemic pressure, you may already recognize that the steepness of this curve is different. And this is more sensitive, hyperemic pressure gradient, and is more proportional to the increase in the stenosis severity. So here is a measurement of one case. Resting PDP is 0.99, almost normal. IFR 0.98. I would say that the DPR, DFR, RFR would be the same, so that it's almost normal from these resting indices, but FFR is positive, 0.79. So what do you expect from these values? If you only measure the resting indices, you should say that the patient may not have any disease and it is completely normal, but this indicates that the disease may be significant and we need revascularization. When I show you the CT scan, there are some disease, but nothing is very critical. So when I see these images, I I would say this one is too insensitive and this one is too sensitive. So we have to understand these sensitivities to the plaque burden or the stenosis severity very well before we apply these indices in our daily practice. So that here is a data that shows that kind of the sensitivity and insensitivity between the resting and hyperemic indices. So this is the changes of the physiologic index according to the increase of the anatomical stenosis severity, and these graph represents the changes of physiologic indices according to the hemodynamic stenosis severity. So this is FFR, this is IFR, this is resting PDPA, and from this figure here and there, you can recognize that the IFR is more sensitive than resting PDPA, and FFR is more sensitive than IFR to stenosis severity. So for some reason, if you want to see the discrimination of the stenosis severity very nicely, you have to choose the hyperemic indices. And if you don't care that much about that kind of sensitive index and just to make a decision on revascularization, I think using IFR will be fine. And the results are exactly the same. Either we use IDOS-derived minimal lumen area and OCT-derived percent area stenosis and also plaque burden. So these are the changes of the resting indices, IFR, DPR, and this line represents the changes of FFR, and this also the same. So that the FFR is sensitive and all the others are less sensitive, but there's certain cut point where the changes of stiffness occurred. So that's generally the cut point for the revascularization. And then these are the backgrounds and cutoff issues, and I would like to briefly talk about the prognostic implication. So here is the prognostic implication as a binary variable. During the 2-year follow-up, this is the low resting PDPA, high resting PDPA, low IFR, low RFR, low DPR, regardless of these resting.
So Ku, is he got disconnected? Hello?
Somebody in the support team, can you get Dr. Ku connected?
Sir, yeah, I think his connection was bad.
So I think someone will join, sir. Anyone can take up the session now. Like we are put in a whole screen. Like someone wants to continue the session. If you'll join in between, we'll add them. Yeah. Okay. So we'll give you a queue of 5, and anyone can continue with the session.
Halfway through.
Now, is Dr. Ku going to come back or need to discuss, or we go to the next speaker? Anybody from the support team, can you help us?
Dr. Ku isn't here. We can move to the next speaker, please.
Yeah, okay. Dr. Bolian, you can invite next speaker.
Yeah, sure. Unless we want anything to discuss on what Ku has talked up to now. If anybody
we are hoping he would come back.
Okay. I think then we will move on to the next talk, that is my experience with RFR and FFR. Dr. Vijay Chandra Reddy. Reddy is there, yeah, please.
Hello. So good afternoon. It's a pleasure to be with you all. Thank you, Dr. Bhavian. So how do I share screen? Is the screen on for you?
Yes.
Thank you. So we had a wonderful introduction. I think halfway it was a very sad thing. We are very familiar. These are the days of physiological indices. We know about FFR. We have been using it quite often in the lab. And basically, we just want to see the maximum achievable blood flow in the presence of stenotic coronary artery. But to get a maximum achievable blood flow, we need a steady state maximal hyperemia. So to get this steady state maximal hyperemia, we are using adenosine, and we are making a lot of assumptions here. The assumptions are plenty. We are taking out the PV, we are thinking that the resistance is very low. Of course, the next speaker is going to talk on the pitfalls of FFR and the adenosine, whether it is working on the microvasculature, cumbersome additional steps, all these were there. And so we're all shifting over to non-hyperemic flow ratios, as Dr. Ku was discussing about. But are they all the same? And what is the relevance in the current scenario with the other types? So this is what he was discussing about. We can use the hyperemic flow indices, of course, or if you're talking about the resting flow indices, there are RFR, which I'd like to show my case now. And of course, you can use the DPR. The Boston is using that. IFR, the Phillips Volcano. The RFR is the Abbott's. And there are some subtle differences, even though the cutoffs are the same, the relevance is the same, how we use these values are the same, doing performance is the same, but there are fundamental differences because this RFR stands out apart from these two, pure diastolic. We'll discuss about it now because it is only diastolic, this is a whole cycle one. So this is a case of a 48-year-old diabetic, anterior STEMI, cardiogenic shock, severe LV dysfunction, creatinine 1.9, mechanically ventilated, taken up for a primary PCI. RCA, as you can see, there is a significant stenosis, but of course, in acute MI, non-culprit vessels may be overestimated, especially if they are on multiple vasopressors, like in this scenario. As usual, mild ramus, LAD, the classical MI lesion, and of course, we do the primary and with a good result. We decide not to do the RCA, creatinine high, cardiogenic shock. So we go ahead for a staged procedure. It comes after 3 or so weeks. Should we do a physiological testing for the RCA? The patient was absolutely asymptomatic. In fact, he was hoping that this might not be needed. And so we said that we might use a flow reserve or a ratio or to find out whether it is important. Anyone could say that these ratios are useful only in intermediate lesions, 50 to 70% diameter narrowing. But then we also know that even in this so-called 70 to 90% stenosis, 20% might be physiologically not significant and we might get away with without an intervention. So the guidelines also reflect this strategy. So he comes up, again, we see the LAD, the result is good, the stent is doing well, and the RCA, we were doing this with the Aries wire, which is the we said we'll go ahead and use this Aries wire. Now we have got the pressure wire X as well, which is also a wireless and more advanced wire than this. So he goes with this wire. And before we show you the numbers, just a little bit of a recapitulation of what Dr. Ku was telling. So many various indices. Why RFR scores are totally, absolutely different from the other two resting indices is it is checking for instantaneous maximum pressure difference. Instantaneous. It could be, the instant could be here, it could be here, it could be even in the systole. Unlike the classical IFRs and DPRs, which capture the pressures, the difference of the gradients only in diastole, here there is a chance that it might pick it up even in systole. And moreover, it is not dedicated to any landmark based on the ECG or the pressure tracing. So this is a non-landmark, non-biased type of reading, which is another big advantage for that. So what we do and how we do it, the same Quantian machine, you connect the wire, Aries wire and wireless, and you get the FFR, you get the RFR as well. So you just have to click whether you want the FFR or RFR, and if it's a practice, you can do both as well. And the advantage, how it differs is, it is a low-pass filter. So the minimum value per cycle are filtered, so we will get in 5 cycles, if you see whichever is the lowest value, that unbiased, you can get that value of the RFR. It is different from the resting PDPA because here we are taking only the lowest possible one, not the mean, unlike the resting PDPA. So this gentleman goes ahead, Aries wire, we get the resting FFR 0.83. So we'd say not enough, and resting RFR was significant, surprisingly very low. So we know it's important. But anyway, we gave a contrast, one shot, and the contrast resting FFR itself was quite low. So of course, so many people use this as a surrogate to avoid adenosine. Of course, use contrast and immediately flush and then measure it. So anyway, RFR significant. So he needs to go ahead and one stent in the RCA, and that does the job. And once we have the pressure wire and you have done the procedure on the pressure wire itself, we always do a pressure at the end of the procedure and see how the gradients are. That's a classical practice in protocols now. The resting FFR after the RCA plasty, 0.98, and RFR 0.97. So quite good. Anything above 0.94 we know are excellent. We just gave the contrast one shot and then check with the so-called semi-hyperemic flow also is 0.95. So good. We can use one wire. You can check the FFR resting or a contrast. You can do the RFR. So one Aries wire and then you do the job. You can do the procedure as well and quite good. So just a contrary, one different type of presentation here is a hypertensive diabetic angina class 2 TFT positive intermediate lesion in LAD asteroid D1, and the treating physician there thought that medical management would suffice because it was only a moderate lesion. Then again, for 2 months, he lapsed into crescendo angina, and he comes for a repeat angio and a physiology-guided PCI of LAD. So I can see here the same thing, that LAD, it looks still anatomically intermediate, so not so critical. So here we are using the Comet with the Boston. This is a DPR. Again, the same things can be done, but if it is an RFR, the advantages are there. You can capture it even in systole. But here we are just like to show you these differences here. The FFR resting was 0.86, DPR was 0.88. So same kind of 0.89 or below. Yes, we can go ahead and do the LAD stenting. And this we do the post-stenting LAD, and of course you check the pressures. You see the FFR, post-procedure 0.97, DPR 0.96, all excellent. And always any of these flow parameters, we draw the wire at the end of the procedure to show that absolutely there is no drift. And the newer generation pressure wire X, which is an advance over the Aries wire. The Certus was there, now the Aries, and now the pressure wire X. The chances of drift are even IFR, and the 0.89, the correlation with IFR 0.89 was excellent to a range of almost 0.01. The correlation is there. All the fire resting indices, if you see, very well class equivalent effect is there. And revalidate FFR also confirms that. The one point would like to highlight why RFR would be my choice if you have to use any of these three is because what we'll discuss this issue. It is able to detect the lowest PDPA during the full cardiac cycle. Just not only diastolic but also systolic is one, and it can potentially unmask stenosis, which might be missed by an IFR or a DPR. So that is the beauty of this. And of course, if you see this slide here, this is the aortic pressure tracing. As you can see, the left coronary flow and the right coronary flow, if you see here, the left coronary flow in diastole, right coronary, even in systole, it is important. So that makes an impact. If you are using, especially in an RCA, you might be better off with an RFR. And if you see in these validated FFR analysis, 12% of times RFR was detected outside diastole in 12% of cardiac cycles. And in the RCA, the number was even big. 32% of cardiac cycles in RCA, in systole, the RFR value was the lowest. So this shows how important it is and how you might miss if you are using IFR or DPR. In fact, the IFR sensitivity when you apply these compared to FFR was very low in this setting, 40% only. So this is one area where RFR would be having an edge over the other non-hyperemic flow ratios. So to summarize, resting flow indices have now become increasingly attractive. We are using very less of adenosine anymore. Sometimes the contrast FFR might itself give some additional clues, but we have recourse to all these available now, and RFR, as I said, has an advantage being a real-time subcycle pressure difference, global cycle validated point. So, thank you.
Thank you. Thank you, Reddy. Very, very nice cases. One or two comments regarding your points. The first case is actually the evaluation of non-cut relation in a STEMI patient. We right now have data on FFR usage in acute as well as dynamic primal trials, but we don't have that strong data on resting indices in evaluating non-population. There are studies ongoing using the IFR. Well, with regard to the RFR, I think this is one of the uncommon cases where you have used RFR. My question is that when IFR is used as resting index, when the lesion severity is 90% and more, it is rather unreliable. So they have included that from 40 to 89% probably that gives a correlation with the blood flow reduction. But when it is severe, probably that may not be very useful. So therefore, especially in the situation of severe microvascular dysfunction in a large anterior MI, the right coronary artery also will be sharing that phenomenon of severe microvascular dysfunction. So I think that's one point where we should be cautious about using resting indices in non-calculation evaluation. And second case, proximal LAD, again in IFR, we have now, Dustin Davis points out that the sub-study that IFR definitely is probably more safe than FFR referral, but they are all hypothesis generating. So in fact, resting indices, we don't have that much of data on certain anatomical situations like left main and proximal LAD. I would like to get your comment on these aspects. And I also would like you to pass on a suggestion where all situations, anatomical as well clinical situations, where you prefer a non-hyperemic ratio like RFR or BFR compared to FFR.
See, as it stands now, I think it's very attractive to jump in totally to non-hyperemic flow ratios. And as you said, if you're dealing with an RCA, RFR would probably become the choice. In acute MI, of course, we are not doing the flow indices in the index procedure. Only when you're calling them for a staged procedure, at that time, they're more valid. During acute MI, during the index primary PCI, indices like resting indices might not be that much accurate. In fact, data is lacking, as you rightly pointed out. So RFR probably there in acute MI, I would not be using any of these flow ratios to assess the non-culprit vessels. But the other issue, where can this RFR be used? Even in serial lesions? Yes. The same way, you just use the RFR wire, the Aries wire, pressure wire X, you just keep withdrawing it, pulling back, and wherever the RFR number, say if it was, say, 0.74 before, and if you're pulling back at one point, it jumps up to 0.86 or a 0.82, you know that is important. If you have 2 or 3 jumps in that artery along the way, you know those are the anatomically important areas, and you can see whichever lesion had the maximum jump, you can use it. So even in serial lesions, they convert some IV infusions and all that can be taken away. So definitely, I think the role for a classical intravenous adenosine hyperemic assessments has fallen off, in my opinion.
Right.
Dr. Varisi, I have a question during acute stage. So you address the culprit and then the non-culprit. If you do with resting indices.
In the non-culprit stage scenario, this was a staged procedure, not in the acute MI scenario. You could use, if you are happy with the, but I think that with the current evidences available, I think non-hyperemic flow ratios will be the choice. I would definitely use an NHFR anyway. The resting FFR is always there. All these gadgets will give a resting FFR. You can also do the contrast FFR anyway, just like that. That is a semi-hyperemic. And then you do the RFR. So all 3 parameters will come with one wire, and then you can make the decisions on that.
No, why I'm asking you is during acute phase, suppose you address the LAD, and then for right, if you do RFR in an acute phase, will it be very different from bringing him back after 1 month and checking it?
I think so, because acute MI, we all know that microvascular dysfunction need not be localized to the culprit vessel. It could be a global phenomenon, well described. And especially, so in that scenario, I think because microvasculature is different, even the epicardial vessels, there are so much of vasopressors going on, hyperadrenergic state. I think the indices, in fact, even the anatomic appearance on the angiogram, QCA, or even by functional parameters, I think there will be disadvantages of checking them in the acute phase.
No, but you have any kind of correlation that in 50% cases you'll be saying, or 20% cases it will be same, or something like that? Or
well, It's difficult to say the number, but definitely I personally would like to stage it, and during the staging, who again will repeat the angiogram and the flow.
Kirana, there is a data from Talianis who has done the non-calculation assessment by FFR during the acute stage, and the FFR did not change after a period about 40 days. It remains almost the same, and the change was only in 1 or 2 cases among the whole lot. So probably it could be done during the acute stage itself. Perhaps to go into for procedure, you can decide later. As a staged procedure is ESC recommending for non-calculation addressing.
The idea is to tell patient confidently that he must come back to do the non-culprit vessel after a few days.
American registry, if I might, good afternoon, sir. Good afternoon, everybody. This is Dr. Ajay Swami speaking.
Yeah, good afternoon.
Nice to see you, sir. I'm sorry, there was a primary service stuck. There is some data from America, the registry-based NHRBC data. They've been using it for about 4 or 5 years now, and they've shown that in more than 90% of patients, the FFR in the non-culprit vessel doesn't change. Unfortunately, this, it doesn't match our experience because, as you said, the patient who's got a proximal LED lesion, you measure the FFR immediately in the RCA at that time, and then come back and do it 4 weeks later. Whereas, as against the other lesion, that means if you have a proximal RCA and you measure it in the LED, the amount of microvasculature which is abnormal in an LED infarction is far higher, and sometimes that leads to difficulty in making decisions. That's my little input from our personal experience. But the Americans have been using it and they feel it works fine in the registry-based data. But their thing is driven more by the ability to get the patient back onto the table because they need insurance permission and they need regulatory authority to bring the patient back to do a second procedure.
So Ajay, if you are doing a proximal LED, you finish doing it, and if you have a lesion in the PD of RCA, if you do it during acute phase, it would hold true. I think it should hold true.
Yeah, it is.
So the majority of data says that it does, but our patients are not majorities and they're not statistics. I think it is far safer. In any case, you're going to bring them back. You are not going to do the PD at the same time unless the patient is in shock, in which case the FFR doesn't have much of a role. And you're going to bring him back to do the FFR.
No. I'm thinking of not bringing him back.
Yes.
I'm talking of a negative value. Like say you do an FFR during acute phase on the non-culprit, and if it is normal, you can tell him that you need to watch this, but may not come back immediately.
I think that's a reasonable call.
Shirish point is excellent in the sense that if it is an insignificant number during the index MI, yes, you can confidently tell you need not come back. If it is a significant number, maybe you might have to revisit it.
So there is some data where they're using 0.85 instead of 0.81 because they do feel that there is some change which is likely to occur depending on the amount of collateralization given by the collateral vessel. So the final answer is still not there. The Europeans don't believe that it is representative immediately. The Americans use it for commercial reasons and say go ahead and use it to say yes or no right away. I'm sorry, that's the best we have.
No, I would say, Ajay, it is a commercial approach. I think it makes so much of sense that when you are sending him, discharging him, whether he should need to come back or no. If you have even a vague guideline, I'm not saying go entirely by that, but at least you can feel confident that he need not come back.
Yes. The safety of that strategy has been demonstrated, sir. No doubt. Yes. It has been demonstrated in registry-based data.
We are not using hyperemic primarily because we don't want anything happening in acute phase. But otherwise, if you are using non-hyperemic, I think it's quite safe to do it.
It's safe, sir, but the amount of data validation is not yet available. That's what I feel. All the data is there only for the hyperemic indices to allow you to defer or to say that it is safe. Non-hyperemic indices in non-culprit vessels, long-term data is limited to small single-center studies and registries, except for the Define and the Sweetheart, in which 25%, and there also they did not use, they excluded acute MIs. They used ACSs, but they didn't use acute MIs in the majority.
All right, thank you, YVC. Excellent talk and good cases. So we move on to the next speaker, and we like to invite Dr. Rajesh Muralidharan, and he will be talking on pitfalls of FFR. I think this is something very important because your pressure system has to be very correct. In addition, there could be so many issues when you're doing an FFR under a complex setting. So let's hear Dr. Rajesh.
Am I audible, sir? I'm audible, sir?
Yeah, you're audible. Yes.
Thank you, sir. Nice to see you all.
Yeah.
Thank you for the kind invitation. It's a proud privilege to be presenting in front of this august audience. I'll be dealing with a very basic topic with regards to fractional flow reserve, the pitfalls in the measurement of fractional flow reserve. So in the next 15 minutes or so, I'll be dealing with about 10 scenarios, which are the most commonly mistaken parts in the measurement of fractional flow reserve. Now, the first part is in the true definition of FFR. Now, FFR is defined as the maximum achievable blood flow in the stenotic artery divided by the maximum blood flow in the same artery without stenosis. So in clinical practice, we measure a surrogate of flow, that is pressure, and then we tell that it is PD by PA, that is fractional flow reserve. But actually, by measuring the pressure, we are measuring a surrogate of flow. So two terms are important in this definition. One is maximum and the other thing is flow. So although we tell that in routine practice, fractional flow reserve is a measure of pressures, it's actually a ratio of flow. The second part is even more important, maximum. You need to have maximum flow in the stenotic artery so as to measure FFR by definition. There are no ifs and buts about it. You need to have maximum flow. So there is nothing called baseline FFR because you need to have flow, maximum. You can give 10 kg, adenosine, whatever it is, and you need to have maximum flow to measure fractional flow reserve. So there is nothing called baseline FFR. You can call it basal PD by PA, that's fine. And there is some evidence to tell that the basal PD by PA of less than 0.92 may be significant. And we can go by that, but not a baseline FFR. The second and one of the most mistaken part is the position of the transducer in the cath lab. The transducer has to be positioned to the table at a reference height at a level of aortic root that is approximately 5 centimeters below the sternum. Now, varying the height of the transducer can alter the hydrostatic forces because we are using fluid-filled systems to measure the pressure and influence the aortic pressure. This is the transducer here, and this is the aortic root here. And depending on whether the transducer is higher or lower or higher, you can have a variation in aortic pressures, as can be seen from this graph. When the pressure transducer is too high, the pressure is too low, or PA is too low, the red is going down. And the pressure, when the fluid-filled transducer is too low, it will lead on to the pressure will be too high. So you need to ensure that the transducer is at the level of the aortic root, which is commonly taken as 5 centimeters below the sternum. This is one of the other errors that we most commonly do in our cath lab. Third is with regard to flushing of the wires. Most often we are in a hurry to do the procedure, or there is a case waiting, you want to get away with this. But the flushing is probably one of the very important part which is seldom taken care of. Now the wire must be flushed and must be kept flat. Where it should be kept, whether it should be kept on the table, on the thighs of the patient, or on the abdomen, so that it's on the same level as the aortic root. These are debatable, but most people do it on the cath lab table itself. Now, any debris on the pressure wire connector, any blood or the saline remnants on the connector may interfere with the PD recording. Contrary to all other scenarios, the connector must be kept dry and free from debris, especially during unpacking and flushing process before calibration. And inappropriate wire calibration will establish inappropriate zero PD, and you ensure that the entire casing is filled with saline and the wire is left as such for at least 60 seconds. That's standard recommendation for the wire to be completely wet and stable, but for the connector, which should be kept dry. So that's how the wire should be prepared prior to the procedure. Now, after this, sometimes we found that there is a big difference between PD and PA once we put the wire. And we press the equalize button, and so that that electronically negates everything. Once there is a large difference, the classical description was that the pressure difference should be less than 5 once inside the guide. If it is more than that, it may be better to recalibrate the wire and do the procedure again and start all over again. So a large difference between PD and PA once the wire is introduced into the guide catheter and then equalizing it is not a great idea. You have to take out the wire, recalibrate it, and redo the procedure. The second most important, the fourth most point is the catheter, the guiding catheter and the catheter size. The larger the catheter size, the more obstructive is it to the lumen. As can be seen from here, in a 5 French, 6 French, and a 7 French catheter, when it's put in a 4 millimeter artery, it itself produces a 70%, 25%, and a 34% diameter stenosis. And the first slide itself tells that you need to have maximum flow. So it's as if the guide catheter is actually clogging or plugging into the coronary ostium. This becomes more aggravated if you are having an ostial stenosis or an ostial disease. Say in this case, you have a 20% diameter stenosis. Again, you will have a 30% stenosis, but the percentage of area stenosis when the guide is engaged is actually more. And so it impedes the maximum flow that can be achieved in the artery. So it basically jeopardizes the very basic concept of FFR of achieving a maximum flow. Next is the guide catheter with side holes. It's preferable to avoid guide catheter with side holes. There are 2 reasons. Suppose you are giving intracoronary adenosine, and you can see that a few of the adenosine will escape through these side holes. So you are not effectively delivering the drug into the coronary artery. You are not producing effective microvascular dilatation. You are not producing maximum flow, and so fractional flow reserve measurement is erroneous. The second point is that there is streaming of blood that occurs through the side holes to the tip of the guide catheter. As can be seen from this cartoon, you can see that the pressure measured proximal to the side holes and with the pressure transducer just outside of the guide catheter or the tip of the guide catheter is different. The blue and the red are different. Now this becomes aggravated if you give a vasodilatory agent. So it's better that you avoid side hole guide catheters during FFR measurement, and if at all using it, you must avoid intracoronary adenosine because the PA or the aortic pressure that is measured may be falsely different. One of the points that is usually forgotten is to take out the introducer needle while equalizing. Now, introducer needle actually creates a vent in the system or in a closed fluid filled system into the atmosphere, so that once the introducer needle is inside the tuhi, it actually creates a vent into the atmosphere, and so the true pressures are not transmitted into the fluid filled system. And as can be seen from this cartoon, you can see that there is a tuhi that's kept inside the introducer needle that's kept inside the tuhi, and the introduction of the introducer needle actually creates a small difference between PD and PA. And you have a bigger introducer needle, you have a larger difference. So it's important that you take out the introducer needle before you equalize. One of the other common problems is where should I place the transducer when measuring the FFR? This is a proximal LAD lesion and you have the pressure wire down. Somebody has kept it just beyond the lesion and somebody has kept it just in the distal part of the vessel. Now, where should the pressure sensor be? As we all know, the pressure sensor is located not at the tip but 30 centimeters from the tip of the wire. So where should the pressure sensor be? Should it be here or should it be here? Now, studies have shown that when the FFR is measured in the distal part of the artery, it is different from that measured at the proximal part of the artery because FFR is also a measure of the myocardium subtended by the vessel. Moreover, there are phenomena of flow eddies as well as pressure recovery that happens just beyond the lesion, which also interferes with the PD measurement. So the classical teaching is that the transducer must be as distally as possible. It must be at least 2 to 3 centimeters distal to the stenosis, and a useful guide would be distal to where a surgeon would graft. Now, avoid a distal lesion. That is important in an effort to put it more distally because you then have the question of 2 plantar lesions or serial lesions coming into question. And once it's a very tortuous distal vessels, there is also the possibility of an accordion effect, which can give rise to a falsely low FFR. And it is a good practice to document the position of the transducer with fluoroscopy for a future reference. One of the other errors that we commonly do is to not to mind the tracings, but just be excited about the value of say 0.85 and or 0.65. So sometimes you are relieved you don't have to stent. Sometimes you are excited that I'm going to stent this. But these tracings are seldom taken care of. Now it's important that the values are always cross-checked with the tracings that we see on the monitor. Now, how do the tracings look like? The PD and PA tracings appear sandwiched once there is no gradient or there is hardly any disease and there is a dicrotic notch in the aortic tracing. Once there is minimal stenosis or minimal hemodynamic obstruction, there appears a gradient in diastole. That is, the gradient appears in diastole. As the stenotic severity increases further, the gradient in diastole becomes larger and there is a small gradient in systole. And in a very severe stenosis, you have a large gradient in diastole as well as a large gradient in systole and an intact dicrotic notch in the PA pressure tracing. So once we get a value of say 0.60, it should actually give rise to a pressure tracing like this. And once we get a value of say 0.85 or 0.88, it should correspond to a pressure tracing like this because there is minimal stenosis. So it also serves as a sort of a cross-check whether you are actually done the procedure correctly. Now, it's also important that some of the fallacies of measurement will be made out by minding the pressure tracings. As in this graph, as you can see, the PD is more than PA in certain circumstances. And this is because of something called a VIP artifact, because the transducer is hitting onto the wall of the artery and producing a falsely high pressures. The machine automatically calculates the lowest FFR value once it is frozen, once we stop recording. But once we check we should check the pressure tracings and ensure that this stopper has come at the right place and not at the point of a altered pressure tracing. Also, it is important that you pull back the wire after your recordings are over and ensure that there is no drift. Once there is a drift, which means that the dicrotic notch is intact in both the PA as well as PD with a large difference in both systole and diastole, you may have to go through the painful procedure of redoing the procedure all again. Now, the last part is with regards to the hyperemic stimuli, which is probably the most important because we need to have maximum flow in the artery. We need to have maximum flow in the artery so as to fulfill the basic definition of FFR. We need to give nitrates to produce epicardial vasodilatation, and one of these agents to produce microvascular dilatation. Now, there is a lot of debate between intravenous versus intracoronary adenosine. Summarize this from this standardization of fractional flow reserve measurements published in JACC by the very innovators of fractional flow reserve. IV adenosine and intracoronary adenosine produces similar effects. The intracoronary adenosine produces more than 95% of maximum hyperemia.
Rajesh? Got disconnected.
Anybody from the support team can get Rajesh back?
Sir, his entire video is lost. I think he's not here with us. We'll have to probably move on. He's lost connection, sir. Have to move to Dr. Sanjeev Rao, I think next. Sanjeev Roy.
of these domains. And CFR is the one which is almost covering the entire domain. While if you look at the FFR, IFR, and other non-hyperemic parameters, they look at the epicardial arteries, which are more than 400 microns, and these are basically the conduit vessel. And CFR, as I said, it is across the domain, where again you can have a pharmacological induction by acetylcholine. The other upcoming parameters include the index of microvascular resistance, and then we have the hyperemic microvascular resistance. We have this is instantaneous hyperemic diastolic velocity pressure ratios. We have the zero flow pressures and wave intensity analysis, and all of them are coming up gradually. And most of this have been validated major trials. Some of them as a randomized controlled trials, if you look at, and some as a retrospective trials. So in nutshell, we have 4 scenarios. Scenario 1, that is outside the cath lab. And here, FFRCT, you can look at here, the NICE has issued a guideline for the use of FFRCT, which recommends it as a most cost-effective option when coronary angiography is done, coronary CT angiography is done, and it shows that CAD is uncertain, functional significance, or it is non-diagnostic. So in other words, this forms a gatekeeper for the entry into the cath lab, also helps you to decide about the strategy that you are going to adopt. The other scenarios, that is before the procedure, you have the hyperemic, that is FFR, and non-hyperemic, we were discussing so far, the IFR, DFR, RFR, and so on. And during the procedure, again, you have a wire-derived, or you can even go for an angiographic-derived FFR. And also the upcoming work on the coronary microcirculation, that is CFR, IMR, and HMR. However, my discussion will be mostly focused on FFR based on before the procedure and during or after the procedure. Now, in absence of a true gold standard of numerous contenders that we have so far, FFR is the strongest contender for the best ischemic parameter so far. It has been most validated in bench test and clinic against surrogate standards like the myocardial perfusion imaging, the PET, and the stress echo, and coupled with clinical outcome studies so far. And you can look at here the steep jump of the number of papers published since the FAME trial. And you have most of the studies which are randomized controlled trials on the FFR and the number of patients who have been studied so far. So as we were defining the FFR so far, it is the PDPA ratio in the maximum hyperemic phase, and those below 0.8 are considered as ischemic and needs to be treated. Above 0.8, it can be deferred. So the nutshell, if I say we have to treat the ischemia and not the stenosis. And this risk stratification tool will help us guide the functional revascularization. And this is the famous, the graph from the FAME trial, where you can see here those which were on angiography looking to be a 50 to 70% of the stenosis, only 35% of them were FFR positive, while those which were appearing to be 71 to 90%, nearly 20% of them were negative. But those above 90% stenotic, most of them had an FFR positive. So just now, Dr. Muralidharan was discussing the step-by-step approach. We need to look at the calibration, the pitfalls, and then take a, because this is very important for the interpretation of the, achieving a proper FFR value and interpreting the results. So the common clinical applications that we have the assessment of intermediate lesion, the serial or the tandem lesion and the diffuse disease, the multivessel disease, the acute coronary syndrome, some of which were being discussed just now, the bifurcation, which includes a non-left main and left main, and finally, which is one of the most underutilized, is the post-PCI. So I'll be dealing most of them except for the intermediate lesion, because that's a common garden variety where most of us are involved with. So to start with, let's look at the scenario of a tandem or serial lesion and a diffuse disease. So this is here, you can find here in the first example, 2 lesions in the RCA. Visually, the distal lesions looking tight, but this lesion and it's very intermediate lesions. We don't know the significance of this. So how do we do that? So this is a PDPA, which is 0.54, which is significant, and the FFR of 0.34. Now, visually, the distal lesions being more tighter, and also distal lesion should be done first. The significant one, it was fixed up, the FFR repeated, and yet PDPA is 0.8 and the FFR is 0.7. So the proximal lesion has to be fixed, and it was done. And post that, it was 0.87. Now, again, mind you, I'll discuss that feature on it is 0.87. It is not, the higher the post PCI you get, the better it is. So I'll be discussing that in the last example of mine. This is another scenario where you have all the arteries having diffuse disease. If you look at the LAD, it is diffuse, the distal circ, the OM, all of them are diffuse disease. Patient is symptomatic, and this is what the you get here. The FFR in the LAD is 0.76. Unfortunately, in the pullback pressure gradient, you don't get as any significant jump. It is a gradually progressive slope, so you cannot pinpoint here which is the culprit vessel. It is a diffusely disease. So this kind of disease are to be left best on medical management. While on the other hand, you have a step jump. Again, in here you can do the pullback and push forward to ascertain that this is a gradient is documented. OM again a steep curve. So this was the distal part of the circumflex was fixed, and rest of them were left on medical management. Again, a similar way, an RCA, very diffuse disease, multiple lesions. So you don't know which one to fix, but you can find here there was some step up here of around 10 in the distal part at this lesion and at this lesion. So they were again fixed, and the post PCI FFR was 0.98. So if I discuss about the tips and tricks in tandem and serial or the diffuse lesion, we need to wire the distal most part of the artery, distal to the distal lesion of interest. We need to induce hyperemia, and if FFR is less than or equal to 0.8, ischemia is established. In such cases, we need to go for a pullback pressure gradient recording under fluoroscopy, or in the advanced lab, nowadays you have the angiocore registration. Wherever the pullback pressure gradient is more than 10, it is considered significant, and in such cases of diffuse disease, the spot stenting can be done. Most severe spots are stented first, technically distally first, and FFR is to be repeated with pullback recording. The rule of thumb is the severe distal lesion can mask the gradient across the proximal lesion more than that of the proximal affecting. Always there is a crosstalk, but the distal lesion impacts the proximal more. So pullback is to be repeated after each spot stenting, and if you have a diffuse gradients, they are best left untouched on medical management. So this is another scenario, that is FFR in multivessel disease. Now let me take you to a hypothetical situation to explain what it should be done. Now let's say there are 4 lesions here, and 2 of them are non-limiting, and rest the marked yellow are the flow-limiting lesions. Now, intrinsic death or risk of death or myocardial infarction because of ischemia is nearly 5% per year if the lesion is ischemic. In case of non-ischemic lesion, it is 1% per year. If this lesion is stented, it is 3% per year. So let's say a hypothetical scenario, if all the lesions, whether it is ischemic or non-ischemic, visually appearing moderate to significant lesions are stented, then 3 into 4, it becomes 12% as the intrinsic risk of death. Now let's say the other scenario where you have done an FFR guided and you stent those lesions which are causing ischemia, that is these 2. So it becomes 2 into 3, that is 6, and if and 1% for the stented lesions, so 8%. So you have achieved the same result for the patient, that is, you have eliminated ischemia, but there is nearly about 35% decrease in the intrinsic risk of death and myocardial infarction. So in other words, it is always better to stent the ischemic lesion rather than stent them all. Now, this is one example where patient had a multiple lesions, patient was referred for surgery. And here again, when the FFR was done, LAD was 0.97, the Ramus 0.9. the circumflex was 0.48, and surprisingly, the RCA, which was looking significant, it was only 0.85. So only the circumflex lesion was stented, and the FFR was 0.96, and following that, patient was doing well. So current, the guideline is we need to do a more of a physiology-guided stenting for the multiple vessel rather than anatomical. And this mismatch has been documented, where you can see here 27% of the patients who were labeled as 3-vessel disease after a physiology guidance, only 9% of them remained 3-vessel, while most of them, I mean like 30% were single-vessel disease. It came out to be 74%. Let me take you to the other scenario, which is FFR in acute coronary syndrome. And we were just discussing some time back about the FFR in acute myocardial infarction. Now, we all know here, whenever you have a myocardial infarction, they decrease the total mass of the viable myocardium. Thereby, it reduces the hyperemic flow and gradient, and hence the FFR increases, like in this case, increase from 0.5 to 0.84 for similar severity of the stenosis. So, therefore, in acute phase of MI, FFR is neither reliable nor useful to assess the culprit lesions, and electrocardiography trumps over the other investigation. 5 days from the infarction, FFR can be used as usual to indicate the residual ischemia of the infarct-related artery or the remote vessel. And the hyperemic myocardial resistance in viable myocardium within the infarct area remains normal, as also in the remote segments. And these are the various studies which has been conducted both in STEMI and NSTEMI patients regarding the FFR. And in nutshell, in acute stage, that is the first 5 to 7 days, you should avoid FFR in the culprit lesion, while non-culprit lesions, we can always carry out and do that. But here, let me share you with another case where something went wrong and I made a mistake here. This patient had come with a history of recent, I won't say 1 month history of exertional angina. And this was basically a jaw pain. And lately, these jaw pains had been appearing after the dinner and even sometimes while resting. So with the idea that this is possibly an ischemic, although there was no ECG changes, but because the frequency of this kind of jaw pain increased, we hospitalized, did an angiography, which none of the lesions looked significant. So we did an FFR in LED, it was 0.96, and the LCX as 0.94. But she continued, she was symptom-free at that point of time, so we shifted her back to the ICU. The moment she was shifted back, she again had a jaw pain and again started perspiring. So back to the cath lab, and this time we do, an OCT, and you can see here a ruptured plaque, and this was stented. What about the bifurcation subset? So bifurcation subset, of course, we need to do the main vessel. And sometimes if we have a lesion in the side branch exclusively, it gives an idea without that those lesions are to be revascularized or not. But there is a concept called branch stills phenomena, which we have to be very careful, because the disease in one of the branches and the main branch, if you look at, can critically affect the flow in the other. So these are a couple of scenarios here where you have an upstream lesion, you have a downstream lesion, and there is a crosstalk, and which might again affect the FFR values, and we need to be very careful. So one of the ways is we do it as a main branch stenting, and then we can assess the side branch. That is another utility, and we have to weigh the options on this. For example, here the main vessel was stented, and the side branch looked more compromised than what it was before. But the FFR when done was 0.93. So we don't go by the oculostenotic reflex. So this was left like this. So again, the side branch can be, FFR can be done, and we need to take a decision whether we need to do a rescue procedure or not. In such cases, again, after the procedure is done, like for example, the kissing balloon dilatation, we can check it. but long-term outcome is not detected. And then once you have done the stenting of the side branch, again the FFR is indicated to decide about how much is the residual ischemia. And the last subset, clinical subset, this is the left main lesions. We need to be very careful if you have an osteal disease of the left main that the equalization should be done in the aorta. Otherwise, it affects, like in this case, where the equalization was not done in the aorta, you get a reading of 0.8. When proper equalization was done, it was 0.66. So in the left main, again, it all depends on whether it is an isolated left main disease or you have a disease downstream. Isolated, which is very infrequent compared to the other subsets, you need to wire both the branches and look at the values. If you have a downstream lesion, the presence of a significant lesion, particularly in the proximal LAD, will affect the measurements in the circumflex. So, but if the circumflex, values are more than 0.85, you can medically manage the left main lesion. But it is less than 0.85, in all probability, there has to be a critical left main lesion. If the lesion extends into the bifurcation as a single unit, again, you need to do more than FFR and IVUS and take a call here. But if there are tandem lesions, so FFR has to be done in both the branches and the critical ones are to be fixed first and then it can be repeated again. The last subset, that is post PCI FFR and the delta FFR. So post PCI FFR is almost always a measure of the residual diffuse disease that is left behind. And suboptimal result is associated with poor prognosis, which is unmodifiable by PCI. There have been contributes more to the prediction of the target vessel failure, particularly in terms of composite cardiac death, myocardial infarction, and revascularization. However, the cutoff values are differ in different studies. All I can say that more it is, the better it is. But if you can look at here, the FFR in syntax 2 was taken and the post PCI as 0.91. The IFR in defined PCI was 0.89 and QFR at 0.89, again in the Hawkeye study. So all the different studies have used a different cutoff parameters. The FFR React and Target FFR are the ongoing studies which will address if further intervention is needed for the residual ischemia, and that will improve the outcome. Another concept is a delta FFR, where you look at the baseline FFR and the post-PCI FFR, and then this has also been correlated with the outcome, and if it is 0.2 or more, then only few of them will have any events in the next 2 years. But if it is higher, then I think many patients may still have an event. So what are the pitfalls? Dr. Muralidharan, Dr. YVC Reddy were already discussing this. So I'm not going into the details. Just to conclude, a highly effective PCI should begin with the end in mind. And the end, it is not only relief of angina, reduction of the spontaneous infarction, there should be least amount of periprocedural injury and least chance of long-term device failure. And FFR can help us achieve this result, both with the pre-PCI FFR, with pullback pressure gradient, post-PCI FFR, and the delta FFR. And here, the new concept which has developed is concept of two-dimensional FFR, where this is the critical line. If you look at the 0.8, if you have a low FFR and you have a focal lesion, this is the ideal subset which improves. If you have a diffuse disease, this has the worst outcome. And if FFR is more than 0.8, whether it is focal or diffuse, we need to treat them medically. Of course, the prognosis differ. So here, the severity of the pre-PCI FFR gives you an idea, and the distribution of the pre-PCI PPG that gives you an idea. So to conclude, FFR is the best known index. Interpretation of FFR is straightforward, but we need to respect the measurements of technique. We should be aware of the artifacts and pitfall. The new non-hyperemic PRs are coming, they're promising. CT-derived FFR is again a promising, which will be the gatekeeper for conventional angiography. and also a guide for revascularization. Angio-derived FFR, again, is comparable to the diagnostic performance and very useful for the post-PCI FFR values. Coronary microvascular disease is an emerging field. The methods of investigation are evolving and will make an impact and make the diagnosing easier. Thank you.
Nice talk, Sanjeev. So I think the various points you made, everything was very clear after your talk. The CT-FFR, I don't think it's very popular in India right now. I'm not even sure whether somebody is doing it or not.
Not really, sir. I think
I would like to make 2 points. One is, the FFR for serial lesions, even today remains to have some problems. It's not foolproof from that. I think that is one area where resting in this like IFR has got definite advantage in the assessment of serial lesions, because you can assess the significance of each lesion separately, and you can then find out the extent of ischemia in the longitudinal way, especially when it is having an angiocorrelation. And then you can have the length of the stent measured, as in your right coronary artery. If you treat the distal lesion first and then find out that the proximal lesion is significant, it ended up with 2 stents. Instead of that, we can cover it with 1 stent when we use a resting index like IFR. So IFR is perhaps compared to FFR in that context is a better option. Second, in post-PCI, correctly you have pointed out that residual ischemia, importance of that. The DEFINE study, one of the different sub-study or study has shown that post-PCI, the functional assessment if you do, then you will find that roughly 24% of our angiographically successful PCI are going out with residual ischemia. And therefore, at the end of that, in that particular study, IFR has been utilized. So if the end of the study, if the IFR was 0.89 less, that means it's ischemic, then you make a pullback and find out is there any reason with the stent. And they found that 40% of that is because of the focal disease inside the stent, and the rest of the 60 was either proximal or distal to the stent, and all of the majority of them are addressable, correctable by repeat stenting or repeat procedures, and therefore the ischemia can be reduced to probably less than 2% at the time of they leave this thing. So I think it is very important that it will be brought out that post-procedure one should assess the functional assessment again. If there is a residual ischemia, try to make a pullback and try to rule out focal explanations for. Diffuse, of course, is correctly pointed out, you leave it with medications because that is because of the residual ischemia, you cannot treat it with stenting. I think it was an excellent talk, Sajid. Thank you. Hiranand, can we proceed to the next one unless...
You have a normal epicardial vessel and you have every reason to believe that there is microcirculation giving angina. Maybe stress stadium is positive. You think FFR helps in these kind of scenario?
No, I think the current concept is, earlier people used to take these, the positive ischemic test as a false alarm. But currently, a lot of emphasis has been given in the microvascular disease, and therefore the estimation of CMR and the other IHMR and all these are evolving. I think that field is still, yet to be defined. We are not doing practicing, but that's a evolving field, and I think in current 1 or 2 years we'll be having more of those kind of estimation to do, and definitely these patients have a microvascular disease.
Okay, Dr. Bolian, we can go to the next. Thank you, Dr. Sanjeev.
I think we'll move on to the physiological lesion assessment mandatory for every PCI in stable coronary artery disease. Dr. Ajay Swami, please.
So I just begin sharing my slides. Is the slide visible, sir?
Yeah, yes, it is visible. Yeah.
So before I begin, my salutations to my teachers, some of whom I see in the August panel here and some of whom are not. We are what we are because of them. We're going to look at physiological lesion assessment and why we feel it should be mandatory for every PCI and a stable PCI. This is a concept which all of us have been speaking about. Patients with angina can have problems in the epicardial vessel or in the microvascular, part of the circulation. And this is an extremely important decision that we make in the lab and outside. Now, why do we need an FFR? This is again something that everybody knows, but for decades, cardiologists have searched for additional methods, something that's better than an angiogram, to look at the physiological stenosis severity and its impact. Because it's known that we're not good at just looking at anatomy alone, and remember we're not seeing anatomy; we're just seeing the lumen. Now, the definition of FFR, as everybody knows, is just what the PD by PA is at maximal hyperemia. How do we look at it in the lab? We take these assumptions, saying that we try and bring resistance down as little as possible and make pressure directly proportional to flow. Thus, the questions that we need to answer is, does an angiogram assess the stenosis severity adequately? Number two, if we do have an FFR and the ability to measure it, does FFR guided intervention compare with angiography? Is there any evidence that FFR guided intervention is better for hard clinical outcomes? Lastly, does FFR predict the natural history of coronary artery disease? Can it be used to measure an endpoint during a procedure? What is our current treatment strategy? And what can we do to make it better? Now, as we all know, angiography does, looking at this RCA and this LAD. The RCA looks tight, but it's actually not tight physiologically. The LAD doesn't look tight, but the LAD is tight and it needs to be addressed. This also accounts for perfusion area. The point has been made earlier, and we'll quickly go past this. That a similar appearing tight lesion on angiogram, significance differs depending on how much of live myocardium it is supplying. And same thing as far as the collaterals are concerned. Thus, FFR incorporates stenosis severity, myocardial territory and viability, and collateral perfusion. In decision making, it is ideally used to guide the diagnostic procedure. Now, this is a slightly different concept to what we normally do. We do the angiogram and say, no, there's nothing significant, no stenosis, you can go. It is used to guide the PCI procedure. This is already in practice, ideally across the world, but we will see how much actually even the Western world uses it. And lastly, to evaluate the PCI procedure, that is to do a FFR post procedure. Thus, all these three are meant to improve patient outcomes. And we just look at two situations. The first situation is this gentleman who's come with a lateral wall MI and he's undergone an angioplasty to the circumflex. He's got an intermediate lesion in the LAD. Now, in our lab, we are doing a little study protocol in which we bring them back at the end of 7 days and optimize the stent, because sometimes you don't get the correct size of the vessel at the initial primary. So we looked at this LAD, and then this is an intermediate stenosis. Now, to send this patient back and then realize that we have not done a complete job and he comes back with another event is an issue. So what do? This is the second situation. This is a 35-year-old male who comes to us with class 3 angina. He has no risk factors, and this is what his coronary anatomy is like. He's got definitely a tight 90% stenosis in the RCA and an intermediate lesions in the proximal LAD, which we need to look at. And the circumflex, which has got multiple tandem lesions, the OM2, which has got an extremely significant looking lesion. Now, how do we look at these? Now, angiography, as we know, can be misleading, and this was brought to us in the frame, although this has been spoken of before. It bears a little repetition, where you can see that patients, even who had 91 to 99% stenosis, were labeled as being tight. 4% of them actually had a negative FFR. Up to 20% of patients with 71 to 90%, in which all of these should definitely have been stenosis, were actually mislabeled. But the 50 to 70% is the one which is actually the eye opener. Up to 35% of these patients are actually mislabeled as being 50 to 70% because these patients are actually suffering from angina because of these lesions, which don't look significant angiographically. But this is a very large number. Remember, one third of patients with 50% to 65% 50 to 70% disease actually have flow limiting, tight, physiologically significant stenosis. And thus, the residual FFR at the end, those who were in the highest tertile of FFR had the best results. Those who had the lowest FFR had actually the highest incidence of post-PCI MACE, up to nearly 40% in the subgroup that was looked at. Looking at the results of intervention in the long term, thus post-PCI with FFR, if one looks at FFR as a continuum, and one looks at patients who get revascularized as against those who don't. The medical treatment patients at a threshold FFR, which we think is around zero point 0.8, this is the optimal threshold where a PCI will actually benefit the patient and bring him from this curve down to this curve, whereas at lesser than this threshold, if one does a PCI, we are actually harming the patient. And this is the threshold at which PCI probably increases the event at high FFR. The concept of FFR guided revasc is based on well structured and consistent randomized controlled trial data and firm clinical outcome data. Now, physiological assessment, do we think it's mandatory in every PCI? I think we should go ahead and say it's probably mandatory in every diagnostic angiogram. Ideally, all diagnostic angiograms in which one performs for chronic stable angina, it's important to perform FFR with the slightest hint of any significance. Every intermediate lesion in single vessel disease must undergo interrogation, and almost all multi-vessel patients should undergo interrogation. ACS patients in non-culprit vessels for FFR, it has been shown that the strategy is safe, it is definitely effective, and gives us very, very good ways to decide what we need to do about our other two vessels. After PCI to predict outcome is also a powerful predictor. FFR extremely good at predicting which patient is going to come back to the lab and which patient is fairly well off. Now, we looked at when we should use FFR. When should we not use FFR? In a patient with typical angina and ischemia on non-invasive testing, I mean, one has an MPI scan in a region supplied by a vessel with a high-grade stenosis, a 90% LAD in a proximal LAD, which has got a reversible perfusion defect on, say, nuclear medicine scan. Probably doesn't require an FFR. A culprit vessel of a STEMI, I think everybody speaks in one voice as far as this situation is concerned, and we don't need to do any kind of interrogation for this particular group, unless one is doing studies for IMR. If the FFR result is not going to change the treatment plan, a vessel that is smaller than 2.25 and you're not going to invade or not perform a procedure, it really doesn't make any difference whether one is going to do an FFR there or not. Now, this is an excellent clinical concept, and the last 3 hours we've only been speaking about physiological indices and how they're used. Despite long-term data showing improved outcomes with FFR-guided decision-making, its use remains significantly underutilized in practice, with FFR being used in 6.1% of interventions for intermediate coronary lesions. And remember, this is in 2012, data drawn from the United States of America. Now, where do we stand today? As far as we are concerned today, for chronic stable angina, if one has an intermediate lesion, it is mandatory to perform an FFR. If it's greater than 0.8, go ahead with the PCI. If it's less than 0.8, OMT is fine. If it's a severe lesion with 70 to 90%, again, FFR is recommended. If it's greater than 90%, then FFR we do not recommend as of today. But remember that up to 2 to 3% of patients who have got 90% lesions in small vessels or in infarct-related vessels, which are old infarct and supplying scars, may not still be significant. But still, this is the current recommendation. What about the future? The future is probably look at an intermediate lesion, perform a contrast FFR, because the problems of adenosine are such that many people do not like to use adenosine. If it's positive, that means a contrast FFR of less than 0.83, go ahead and perform the PCI. If it's negative, if it's greater than 0.89, we can defer the PCI. Equivocal, we perform the FFR with adenosine and then go ahead and perform the procedure. What happened to our patient? A lateral MI with a circumflex PCI 7 days prior. We interrogated his LAD and we found that he had a FFR of 0.83. Nothing needed to be done. And the second patient, the 35-year-old male, we interrogated everything after performing angioplasty to the RCA, found a 0.9 for the LAD, did a pullback, found that the most significant lesion was in the proximal LAD, fixed that, and then did a post-PCI, again a 0.9. This is not ideal, but since the patient had diffuse disease in the distal LAD, this was the best result we could get. It was 0.9 from the stent as well as from the distal LAD. Thank you for your attention. I should be glad to answer your questions.
Thank you, Ajay, for that brilliant talk. When you list out where FFR should not be done, you did not write non-culprit vessel during acute STEMI.
No, I didn't say that, sir.
No, you did not say that, but you should say that or you should not.
No, I think we should not. Both the Dynami, the Primalty, and the Compare Acute have shown that it is safe to defer intervention in a null-culprit vessel in case the FFR in that is negative. There is no problem. It is safe.
But it is safe, all right, but all your earlier speakers were saying that don't do it during acute phase. Not for the safety point of view, but the reliability point of view.
So again, we have these 3 large trials which have shown that it is reliable in the short term. The problem is that, all these 3, I mean, I delivered another talk about 3-4 days back in which we just reviewed what should we do for the non-culprit vessel in case one has access to FFR and in case one does not have access. I could summarize those slides and show you, although my talk today was supposed to be on stable angina. So that is, I think, a particular different subset. And it appears to be safe to defer. My only rider is the amount of microvasculature.
No. I'm not talking of the safety. I'm talking of reliability. And would you do it during STEMI, the non-culprit FFR?
So we don't.
Dr. Bolian, you said you would not do, right?
We don't give adenosine in the non-culprit vessel at all. The case
you can do resting. You can do resting.
No, resting is not at all validated.
I think, but there are going to be other tests, not FFR.
Yes.
But all resting indices which are not FFR. Dr. Bolian, you are saying no, don't do it, isn't it?
No, I didn't say. Actually, we can do in the acute stage. Suppose there is a LAD primary done and an RCA has a lesion there which is non-culprit. You can do a FFR interrogation during the acute phase itself. And if it is positive, you can tell the relatives that this patient requires a procedure. Whether to do the procedure depends upon whether you believe in acute multivessel angioplasty or a stage 1. So you can do that, and it is supposed to be reliable because studies have shown that after a gap of about 30 to 45 days, the change in the FFR, which is obtained during the acute phase, is not different. So one could do that. Well, the question of giving adenosine and then you produce some discomfort of the patient is a technical reasons. And regarding the resting index, yes, please.
No, you guys are not getting my point correctly. Is Sanjeev also there? I mean, Sanjeev, YVC, all of you said that during acute phase, non-culprit vessel, the microcirculation is affected on both sides, the non-culprit side as well as the culprit side. So it should not be done.
No, so am I audible? I I can tell you that there is, I'll show the data also. Dr. Hemant is Dr. Viveka here. So I think it is put to rest that, as Dr. Bahadur rightly said, that non-culprit artery you can do with, high index of reliability. So there is no doubt. So, and that is why the data is there. And if you look at the, non-culprit artery, there is no doubt about that. You have to do it. And that has, in fact, as you were seeing initially, that on table you can give a verdict to the patient that whether you have to come back or not, and it has a real relevance. In fact, the data also suggested that if it is a straightforward plastic, you can even do it during the index setting as well.
That's right.
Actually, Dynamic 3 primal T as well as acute compare has shown beyond doubt the safety of non-culprit vessel PCA, and it has, those studies have proven beyond doubt there is absolute reduction in the MACE rate as well as the relative reduction. So you can give very safely, you can do the FFR very safely. Only particularly in right coronary, you should be very careful when you have any hypotension, bradycardia. But otherwise, it's definitely indicated. They have proven beyond doubt.
No. Safety is not an issue. You can do very well.
Yeah.
Not an issue.
Careful. Yeah.
But the only thing is that clinical application.
I mean, careful is always there. I mean,
These studies have shown very clear results.
I understand your question and your concern. There is no doubt that it is reliable in the sense that FFR in the non-culprit vessel done on day 2 or day 0 and FFR done day 45 do not differ significantly.
Yeah.
Now, this has been tested in large double-blind randomized controlled trials, compare acute, dynamic, and it has been shown that this strategy can be supported by safety as well as efficacy. Now, beyond that, I don't know what more we can say because...
But I think one point, we should not go with the idea that it is mandatory to do an FFR-based revascularization. Because even today, it is not consensus. After the complete trial, which incorporates more than 4,000 patients, it has not shown that angiography-based decision on non-correlation is
Ajay and Dr. Bolian, you do an FFR today on the non-culprit during STEMI, during PAMI, and it is positive. So when he comes back after 1 month, you call him back because it is a positive.
Right.
After 1 month, do you need to repeat or you can just go ahead with whatever you assess during the acute phase? That is called reliability.
Yeah, that is
what I would say reliability.
That is what I'm saying, that there is no significant difference on day 0 and day 45. That has been...
It's very reliable.
It is reliable and it can be the basis of your decision. The problem is that you can't often do it in everybody. You can't do it in so many people with acute MI, and so many people will not be able to do it. I mean, for so many other reasons. Reliability question has been answered.
Dr. Hiramat, sir, I think you were more concerned about the microvasculature resistance in the infarcted and non-infarcted. Now, studies have shown that if the myocardium is not infarcted, it won't make any difference in the microvascular resistance whether you do it on day 0 or after 4 weeks. So the FFR values done on day 0 for a non-culprit, non-infarcted vessels remain same. If it is positive, then that is as reliable as you do later on based on that report. The only concern, as everybody is more concerned, is day-to-day practice. We usually do not do. That's a different challenge. Even if it is positive, we do not stent because we'll always like to
do if it is going to be reliable, and safety is not a concern. I think
reliable, absolutely reliable and reproducible, both reliable and reproducible.
Sir, other issue. Sir, one request. Next talk, Dr. Viveka is covering these all the latest trials. Let him just finish and then we can discuss later after these talks, if it is okay. Because he was trying to see the same things which he is mentioning again.
Okay, Srinivas, you are the boss, so whatever you say.
No, please. Because there will be a little bit repetition for him again. The same things he is going to talk on. Thank you, sir.
Okay, thank you.
Yes, sir, can I make a point? Can I ask you a question, sir? Dr. Rajesh here, sir.
Yeah, so okay. So I think we had very interesting discussion, and let's look into the data. So there will be some repetition of the because these slides, and we will have the. So we already have understood that what the FFR is. So we don't need to define that. We need to look at the lesion severity, and so one of the reasons why FFR is important, that the interventional cardiology had gone into a little disrepute simply because of ocular dilatory reflex. So if we intervene in our patients with physiology, that is what, so I think this slide has also been discussed in detail. And here again, if you look at the, is the PCI as gold standard as medical therapy in understanding the ischemia? And again, one of the drawback of the COURAGE trial, which brought that medical therapy was as good as PCI, was that it was not physiologically guided therapy trial. So obviously there would have been a lot of overlap in that situation. So if you look at the data, that FFR guided PCI leads to 35% risk reduction in death and MI compared to angiogram derived only. So this is one major reason. And if you look at this is data from the FAME. So the routine adoption of FFR in clinical practice would allow the physician to make right decision for the right patient, and more importantly at the right time, which Dr. Hiramath was saying, that when you have the patient on table, you need to get the answer, and that should be a very reliable answer, and that should be long-term binding as well, where the outcomes can be seen. So the pressure wire guided PCI is superior to medical therapy alone, and this data again, if you look at from the FAME, that shows that 2-year survival free of miss, and you can see clearly that PCI with medical therapy versus medical therapy alone. The routine adoption of FFR in clinical practice allows the physician to make the right decision for the right patient and at the right time. So this is very, very important aspect. Again, what Dr. Sanjeev also showed, and it was again discussed that it should be a routine practice, and there is enough data to suggest that when we start a PCI or intervention, it should start with FFR and it should finish with an FFR, so that we know the long-term outcome of these patients, whether they will come back sooner or not. So the over post PCI FFR, which is less than 0.88, may be an indication to use adjunctive imaging modalities to identify the residual disease and to optimize the stenting procedure, as well as we had discussed that in stent maximum issues have been seen, and it can be resolved by imaging either by IVUS or OCT, we can see. So let's look at the three most data in three settings where the most important mortality or outcome data would be predicted. That is left main and proximal LAD, multivessel PCI, I think it has already been discussed, and acute coronary syndrome. And let's look at the data, what it suggests. The FFR can accurately assess the left main and proximal LAD treatment needs. FFR can lead to a recategorization of angiographic three-vessel disease. So this data has been discussed. And FFR guided complete revascularization of acute coronary syndrome patient reduces the cost and the risk of events as well. So I think if you look at the different modality, it has been discussed, the most reliable of the lot is the FFR, and that should be done as against the conventional coronary angiogram or even the contrast FFR. So let's look at the data in left main and proximal LAD. So FFR guided left main deferral is shown to be safe, and this data of more than 525 patients are there. And this study goal was that can FFR help determine when to defer the CABG for patients with left main, or for that matter intervention in these patients. And this was the meta-analysis of more than 500 patients studied at relative risk of primary endpoint in all-cause mortality, the non-fatal myocardial infarction, and revascularization in LMCA lesions. And this study confirmed that LMCA FFR threshold of 0.80 may be used to defer the revascularization. So that's a very important point. And patients deferred to medical therapy by FFR had equivalent clinical outcomes as those deferred for CABG. So again, it means that in left main situation also it is quite reliable. And as it has been discussed that when we do FFR of left main for the decision making, we need to do for both the LAD and circumflex. So if the LAD and LCX is both the FFR is more than 80, then optimal medical therapy as per this study is optimal. And if the LAD or LCX it is less than 0.8, then if it is both are less than 0.8, then also we need to revascularize, and we need to do be guided by FFR pullback tracing. And this data from Modi showed that the purpose and left main treatment algorithm for FFR guided and its core, and IFR currently lacks the data to support the use in left main disease assessment, which has already been discussed before. ACC supports the use of FFR to assess the severity of left main, and these data again showed that even you can do an image guided, but FFR may be used as first modality to assess the ambiguous left main severity. Sometimes it may not be clear, so combination of imaging plus the FFR would be the name of the game in these situations. If you look at the data of FFR in multi-vessel disease, this is what I was referring to, that angiographic 3-vessel disease can turn out to be, here you can see that the triple vessel disease has come out to be only 14% would be true triple vessel disease, 43% would be having double vessel disease, and single vessel disease would be 34%. So initially these patients used to go for CABG, but this data again from the FRAME trial did show, and that is why we now calculate as functional syntax score and functional triple vessel disease, how the significance is. This is again a very hot topic which we have discussed, that in acute coronary syndrome, how should we go about? So obviously, we know there are 3 settings: STEMI, non-STEMI, and unstable angina. So in all these situations, we need to see whether the FFR can be done, and then as we know that the with the dynamic and complete vessel trial, the data suggest that we can do it safely. So this is why if you look at the culprit vessel, clear culprit if it is stable coronary artery disease, and in non-culprit in stable situation you can do, and in patients who have got non-ST elevation acute myocardial infarction ACS, there again in culprit lesion the result will not be good, accurate in acute setting as it would be in ST elevation MI also. But in non-culprit lesion, in all 3 situations, the guideline again says that we can safely do it, and there is ample data to support this. So again, ACC supports FFR-guided complete revascularization of non-culprit lesions also. It is up to the operator to decide whether they want to do it in the same setting or they want to do it later on. So in the presence of an intermediate severity non-culprit artery stenosis, the revascularization was related as appropriate therapy provided that FFR was less than or equal to 0.8. So this is very important that you can do in non-culprit artery lesion, and you can also revascularize at the same setting if the operator feels that it is an uncomplicated and easy procedure. It is rarely appropriate to perform PCI in patients with acute coronary syndrome for symptomatic patients with intermediate severity non-culprit artery stenosis in the absence of testing to demonstrate the functional significance. So meaning thereby that we should be doing physiological assessment in non-culprit artery lesion, and then only we should proceed for revascularization. As in the previous lectures also it has been said that it can cause sometimes during the acute myocardial infarction or ACS, the patients may have some spasm in the artery and there can be overestimation. So this is again compare acute data was being discussed, and this clearly showed that the Compare Acute is a randomized trial which was published in NEJM in 2017. It was designed to investigate the validity of the current guidelines for complete versus infarct-related artery-only revascularization in the setting of ST elevation myocardial infarction with multi-vessel disease. And again, this is the largest study of this kind, nearly 900 patients with multi-vessel disease and ST elevation MI were involved. And this study demonstrated that FFR-guided complete revascularization clearly reduces the risk of events compared to conventional angiographic-guided treatment of infarct-related artery lesions alone. And this is how the trial design was. And you could see that the follow-up at 30 days, 1 year, 2 year, and 3 years follow-up data is there. And that clearly showed that the FFR-guided complete revascularization did significantly better than the angiographic guided therapy alone. So FFR-guided revascularization of non-infarct-related arteries reduced the MACE rate. You can see this is the curve. The MACE rates are infarct-related artery angiographic guided therapy alone would have worse outcome than the FFR guided therapy. And if you could see that the patient outcome from this compare acute data, that FFR guided complete revascularization is safe and feasible in STEMI multivessel disease. It reduces the risk of event compared to an angio-guided infarct-related only treatment strategy. And patients in FFR guided treatment arm had 13% lower MACE rates, which resulted in a 65% risk reduction in MACE at 1 year compared to patients with undergoing angio-guided infarct-related artery only treatment. And untreated FFR positive non-IRA lesions are associated with a 31% incidence of MACE at 1 year. So again, what was very aptly questioned by Dr. Keramal was that if the patient needs it, so you have an answer on table, and if you don't treat the FFR positive arteries, non-culprit arteries, then you can see that the 1 year MACE is again quite significantly higher if you don't treat it. So the key conclusion for compare acute cost analysis was that the complete revascularization in acute MI setting PCI procedure with FFR guided can result in lower social cost and economical cost also, because the patient will have reduced number of re-interventions also. So this new evidence demonstrated that reduction in clinical events, that re-intervention leads to a reduction in cost from the national health policy perspectives as well. In bifurcation lesion, I think it's already been discussed, and these are the latest pressure wire extended studies and clinically validated in stable and ACS data. So these the data and the recent trials which are there even in ACS settings, in CAVG settings, would be there, which the results will be coming soon. And again, from 2001 DEFR data till, the compare acute data. So I think we can conclude that we have got a lot of data right now to support that our, not only chronic stable angina patients profile should be, FFR should be mandatory in most of the cases, wherever the borderline lesions are there or we are not sure. But in acute coronary syndrome also, especially in acute myocardial infarction also, based on this lot of data, we should be doing in multivessel PCI, multivessel acute myocardial infarction settings, we should do FFR so that we give correct treatment to our patients. So thank you very much for your kind attention. And if there is any question, I'll be more than happy to answer that.
Thank you, Rebecca. What I like most is in that pyramid of accuracy slide, the bottom one was the coin flip.
Yeah.
I don't know whether you remember.
It's like head or tail.
I don't know, but it's truly, from coin flip, yes, to leave proximal LAD, which is angiographically looking important, leave it for medical treatment or defer it based on FFR accuracy. I think it's a big change of mind for many of us, and I'm sure this is where the trust level is coming to in physiologic testing. What about the ostial left main, Rebecca? Would you use, you cannot put an intracoronary adenosine in this case. That is accepted. You have to use the intravenous adenosine, keep the guide out, and then measure then it can be reliable. But I think that is one area where FFR is probably not going to be very reliable.
That's right.
You trust IVUS only, I guess, because even OCT becomes very difficult for ostial.
Through ostial lesions, it will be difficult, especially if they are angulated.
Yes.
Sir, I think we'll move on. 3:30, we have a live case coming up, so I request you to pause for the next lecture and see the FFR in multivessel.
Yeah, good afternoon, everyone. Am I audible?
Yes.
Yeah. So I think my previous speakers made my job very simpler. I will emphasize. Mainly on cases. So main intention when you do the FFR, it minimizes the number of stents. Moderate LV dysfunction. The patient had a triple valve dysfunction. And the patient also, one of his classmates is a cardiologist practicing in Vijayawada. Then I spoke to him. I sent him WhatsApp images. Then he was suggesting give thrombin therapy, go for bypass surgery like that. But ongoing ST elevation on the patient, young patient. Then we said, okay, we'll go ahead with the primary PC of the LAD. Then subsequently do the FFR. So this is the LAD. Then we did the primary PCF LAD, then 3 × 35 March row stent, then this is the post PCR result, and 48 hours later, then we did the FFR study. Then that time the angio LAD is nicely flowing, stent is very well patent, and you can see the L6 prognoly appears to be tight on angiography, and you see the right coronary progmal to mid, and there is a distally tight lesion. You can see the distal. So then we did the stenting of the right coronary. Then then did the FFR study of the L6 and IM. You can see the 0.89 and 0.87. So my L6 was negative, though initially we thought of doing the advice like bypass surgery. And we have ongoing chest pain, primary PCI, RCA, it changed the plan. And now almost this was done about 3 years ago, and patient is doing well. So this one I wanted to skip because already Ajay Swami emphasized this is there's enough data that in STEMI, non-culprit result, definitely when you do the PCI, the event rate is much lower, but is almost 28% reduction in the MACE rate. That is a relative reduction, and 4.5% reduction of MACE rate. But even all causes myocardial infarction. So the secondary points are also. But surprisingly, there's no difference in death, all cause death, the angio versus the FFR group. And this is the one in meta-analysis has shown the single most important factor which predicted the outcome, at least one FFR positive lesion. In all subsets of patients, like with acute coronary or stable coronary artery disease, above 60 or below 60, the patient, irrespective of sex and whether the patient is diabetic or not, that if the FFR positive undergoing PCA, the FFR guided PCA favored better compared to medical therapy. This is one negative study, future study, where they have shown, they studied in, this is a France government sponsored program, the ACS, including STEMI patient with stable patients, all patients with multivessel disease, but there is no change in the MACE compared to angio-guided, but unfortunately the FFR showed more death rate, almost double the rate. This study was stopped very early due to an excess mortality, and high death rate in FFR was explained because of the more patients with the syntax score of more than 32 in PCA group and higher rate of ADAC PCA, and FFR patients, more severe disease, more three-vessel disease, that might have led to increased mortality rate in this study, and similar MACE rate like 14.4% versus 14.6, but twofold increase in the rise of deaths, that is in 3.7% versus 1.5% in FFR versus angio-guided. Even Prisma meta-analysis also has shown very clearly non-significant favorable MACE outcome, that is FFR group versus angio-guided PCI. So FFR is a reliable tool under any hemodynamic situation as long as the maximal hyperemia is achieved. FFR of non-infarct related lesions in STEMI is reliable and reproducible. FFR in main vessel, multi-vessel STEMI patients is safe with a minimal risk, that is 0.29, as long as is done in experienced hands. In multi-vessel STEMI, patients, a large proportion of non-infarct related lesions are FFR negative and have a good prognosis, and FFR guided PCI definitely will change this outcome. Like negative patients, you can safely leave them, and optimal timing of FFR guided revascularization in STEMI patients is not yet determined. And this is the last case I wanted to show. This is you see the patient underwent bypass surgery, the importance of functional testing.
Can you conclude, because
it's over. The patient underwent bypass surgery 2 years ago, and you see the tight appears to be a very significant region of the left main. And then, within 2 years, graft got closed. Then we did the FFR study, right coronary normal, FR negative. Then patient presented with only palpitation with atrial fibrillation, but FFR, LAD and L6. Non-functional, if you put the graft, most likely they may close. So with this one, there are enough data. Then I will conclude this one. So FFR simplify the procedure and reduce the unnecessary complex interventions. Needs an adequate understanding of the assessment of bifurcation, pullback readings, and possible pitfalls of FFR. If needed, don't hesitate to perform post-PCI FFR assessment of main vessel and side branch, and ischemic burden is more important than the presence of ischemia. Particularly, at least you consider only vessels with more than 10% ischemic burden only. If the small vessel with a less than 10% ischemic burden, even if you do, it will not change any outcome. Always weigh the risk versus benefit. Thank you one and all for giving me this opportunity.
Thank you, Sridhar. You concluded. As Dr. Hiramat sir, I think a lot of discussion happened. Live case, Pratap is ready with the live case. They are going on calling. We request Dr. Shivkumar, Dr. YVC Reddy, next chairpersons also to join. And we have changed the pattern. We don't come out of the rooms and go into the rooms. New people will be added to the same room, sir. So we request, if you can, to continue and moderate this live case, Dr. Hiramat. We are learning each day also. This way, I think the waste time in between shifting cases can be avoided. Now we request organizer the Harshika to connect onto the live case from Pratap. The plan is what we told them, sir, is Dr. Pratap will be live for initial 15 minutes. He's doing a left main case with image guidance. And then we'll go to Jaipur for Ravindra Rao for a tower. Then we'll come back to Pratap in the last 15 minutes, sir. With this, I request you to take over. Dr. Shivkumar, Dr. Hiramat sir, and all of you can continue. And we'll go live. I think we can started seeing them live, sir. You can. Dr. Nikhil is also there, and whoever can coordinate, Dr. Sridhar, everybody can continue. My friend Hygriv also is seen. This way, a lot of interaction could happen. YVC Ray is also there. Over to you, Dr. Pratap. Can you hear us? Can you make Pratap's feed bigger? Hello. Harshita, who is doing this? Can you make Pratap's feed coming bigger?
Yes.
And like as others should be smaller.
Yes.
I think you.
Can you hear me?
Yeah, we can see you and hear you. They're just organizing the display, right?
Yes. Can everyone pin the video of Medicina Hospital and
I'm doing that.
Yeah.
Okay. Now we can see it. Are you able to see, sir? Hiramat sir, bigger?
Can we move it? Can we move? Rajiv, we can start.
Each of us are supposed to pin. You can do it, from our side, from the organizer side, pin the video of Pratap, so that everybody will see it big. I am able to see it bigger now, but others are not able to see it able.
Can everybody see?
Yeah. Go ahead, Pratap.
Okay, no, we are not able to see the screen.
Not able to see? From you, on the screen button on the right top. Video.
Yeah, good afternoon to all. Can you hear me?
Yeah, now we can see it.
Yeah, good afternoon. We have a 45-year-old gentleman who presented with ACS antiviral MI on 27th of last month. He was thrombolized there. He's a known hypertensive not on medication. Echo shows mild LV dysfunction. His creatinine is normal. He underwent angiogram over there, which showed a LMCA plus double vessel disease. Next slide, please. This is an angiogram. We can see a significant distal LMCA disease with a critical ostial LAD and a borderline looking circumflex disease. There is another lesion in the middle LAD, which also doesn't look very significant. We have to do imaging to confirm it. Next slide. The RSA has some plaque, but no significant disease. So this is a status. The syntax score is 26. So he came to us, and since it's a recent ACS, we plan for a PCI to the LMCA.
I think Srinivas, we can discuss. Srinivas, can you see us?
Hello.
Pratap, we can see you. Can you just discuss the case? And this is the case. Actually, the first today's angiogram. Can you show the first angio? Yeah. So just go to the angiogram. No, they have to show you. It should come down. Play.
That's not a good case, I'm saying, for demonstration. Thanks for cooperation and identifying such good case. Go ahead. Shukmar, you can
this
talk.
This is the angiogram today. So we decided to do, we wanted to understand two things. One is actually how significant is ostial circumflex and how significant is the mid-LAD lesion. So we decided to do an image-guided PCI. So we decided to take OCT-guided angioplasty today. So the first, we just did a, next. Put two wires, one into the LAD, one into the circumflex.
I know you like it.
Hello?
Yeah, go ahead, Pratap.
Okay, next. We did a balloon dilatation in the ostial LAD because we wanted to see an OCT imaging means you require a real run, otherwise we won't get it. Next. A balloon dilatation with a 2.5 millimeter balloon. We went up to 10 atmosphere and dilated. Next. This is the first OCT run. We will actually go to the OCT now. Can you just explain?
Yeah, you can see the OCT run from distal to proximal. Here we can see the distal, the vessel is small, around 2.25 to 2.5. Here we are coming into the middle LAD lesion. That looks significant. Now, in between part where there is no much significant disease. Again, the vessel size is quite large here, around 4.
Some dissection flap.
Yeah, now there is some dissection flap created by the balloon dilatation. Critical ostial lesion. We are entering into the LMCA. We can see 2 wires there. And distal LMCA again looks 5.3 millimeters square, again significant. Now into the LMCA. Again, the proximal part is relatively disease-free, and LMCA looks like a 4.5 vessel.
Can you just show the measurements?
The LMCA we had taken the measurements looks like a 4.5 vessel. And here the distal LMCA, the lumen area is only 5.3, significant disease there. The tightest segment is
post-proximal part of the lady.
Yeah, this is around 1.6. There is some dissection over there. And the middle LAD where it is relatively disease-free, again the size is very good. It's 4.2 almost. So if at all we are planning for LMC to LAD stent, we can land the proximal stent here.
With an estimate of 22 millimeters.
Yeah, the length from here to the ostial LMC is around 22 millimeters. And again, if you go a little more distally, again significant plaque is there. Here the lumen is quite small. Again, we got a critical area of around 1.5 here. So this lesion also should be addressed. And distally as we go, here there is not much of a plaque, but the vessel is quite small. The reference we got is 2.8 2.3.
2.3. So if you are planning to putting a stent, I think we lost three.
No. We
Okay.
can,
So the LMC is actually 4.7 millimeter vessel, and the proximal LED is like a 4.3 vessel. Distal lesion is very significant, but that is the vessel distal to that is looking like a 2.3 vessel. And the circumflex run also we have done. Next OCT run.
yeah, that's the important information to decide the type of strategy, whether LCX or is involved.
Yeah, we did a circ run also. This is a circ run.
We can see the circ run.
Angiographically, okay.
Angiographically look like 50-60%. So we decided to do a circ run, then take a decision.
Again, here the proximal part is relatively disease-free, but when we reach up to the ostium here, we can see some plaque, eccentric plaque coming. Yeah. This is the ostial part. You can see the areas around only 3.0. It's fairly okay borderline, but still this area looks a little more tighter.
This like very tight disease, 2.42 is the lumen area.
It's eccentric plaque, that's why we're not probably seeing in the angiogram. And again, once we are reaching into the LMC, distal is also...
microdissection must have happened after the initial balloon dilatation.
Correct. That is also one point. So actually,
unless it is very critical, Pratap, we can avoid doing a pre-dilatation and do a OCT before. But if it obviously lesion is very critical where the flow is not there, we are forced to pre-dilate. But LED lesion proximally, we could have managed even without pre-dilating, looking with OCT, it looked to me. But anyway, you have done it. This is the problem with pre-dilate before assessing. Some plaque shift or something could happen to LCX ostium and some mild lesion which was there could have progressed. So anyway, that is also, you can argue saying that while stenting also same thing could have happened. But
I think that is the right thing. But at the same time, by seeing this lesion without dilatation, with the balloon dilatation in OCT, OCT guidance will be a little difficult and you may not get the proper imaging of the OCT.
Yeah, if it's tighter, no flow, then we won't get image, right?
Shivkumar here.
Yeah, please. Yeah. Please, Shiva, tell me, Shiva.
Yeah, hi, how are you? I know you are an expert on left main and I've been seeing you for so many years on left main. That's really great to see you again tackling the left main. Two things. Would you like to do FFR to LCX and then decide, although the OCT lesion looks eccentric and borderline, I'm still not convinced with the circumflex disease.
But actually, Shiva, what you can see, there is a small dissection in the ostial part of the circumflex, number one. Number two, the lesion with the area in that region is only 2.3. But the problem is actually, even if the OCT is, FFR is looking negative, that with the small dissection there, I'm a little bit worried. As Srinivas pointed out, I dilated the osteoproximal part of the LED, which the balloon was little extending to the LMCA. So probably it would create a long-term effect. And if you are going for otherwise, you have got a provisional stenting. Provisional stenting, you will be landing with a tap or a pull-out. So I think I will prefer to do a DK crush or a DK mini crush. Actually, that would be the nano technique, DK nano technique. That would be our idea of doing. So I don't think we should not, you can prepare and very well and do a better result in LMCA rather than going for a halfway result. What do you think?
Yeah, fine. That's okay. I do there's some dissection.
One announcement to all the participants. I think I was told that 1,300 participants logged in for a live case, Pratap. One thing is you shouldn't chat among yourselves. Sometimes it is getting displayed and going to live stream the chatting and interfering with this case images. So the live stream, don't chat during the live case, please. Go ahead, Pratap.
Okay. So now we will be planning for a 4 millimeter stent and the LMC circumflex. What is the lumen area? The proximal part.
Again, 3.5 vessel.
Circ is actually, osteoproximal part is actually 3.5 vessel. So we will put a short stem in circumflex. We will put a balloon dilatation. We will do a DK nano crush. That will be our plan. So we will take a 3 millimeter stent. 3.5 in circumflex, and LMC will take a 4 millimeter stent because distal to the proximal LED look like 4.2 and LMC is 4.5. So we can take either a 4.5. There is a small problem with the 4.5. My tension is when you take a 4.5, the proximal part of the LED we may get into dissection. Or otherwise, you take a 4.5 stent, you go a little less than nominal, then you can get a 4.25 and then come out, and proximal part you can dilate with a 5 millimeter balloon.
The advantage here is anyway you have another lesion which can tackle up with another lesser size stent. Fortunately, you have to put another smaller size stent anyway in the mid portion of LED. If it dissects distality, then probably you will cover it up. But what I would do, Pratap, here is because we have LCX as a little lesser type of lesion, though dissections you're seeing it. If you do a crossover and then assess LCX, how it behaves, then we can always take another small stent and go through that also. That can also be done if LCX. Generally, what we do LCX first is when you LCX ostium has a tight stenosis or LCX lesion is more critical, we follow what you are doing it. Otherwise, if LCX ostium is not very tight, I think if they feel that you can address the middle LED, put a appropriate size stent there, then come back and put a left main to LED stent, and then address LCX and see how it behaves. Then we can always think about doing else. That is another way of looking at things. If we are not too convinced about LCX lesion, but here you want to do LCX first.
LCX first because I am planning for a DK crush. That is why.
Yeah.
Pratap, I agree with Srinivas that probably why don't you address the middle LED first and then you can tackle left main LCX and LED at one go.
My plan is actually to put a 4 mm stent and then distally I can sizing the stent distally. Otherwise, you may land up in a small stent. Then your stent sizing will be a problem in the proximal LED, which is a very big size in the 4 mm. The distal LED part is actually only a 2.5. If you are just stenting is little short about that, then you will be in trouble. Whether you require a stent actually to be the second stent and the first stent actually. You may not be in, there will be a small gap will be created and will be creating unnecessary tension. Otherwise,
anyway, it is straightforward. You're tracking the stent even from the left main stent may not be that difficult because the LCX going is a problem. But middle LED, generally we advocate doing distal lesions first. But as Pratap mentioned, there's a worry of edge dissection because size stent ending in the LED distally. That's what is worry. Okay,
that is what is my worry. Number one, actually, we don't want actually taking a stent down even after some time also there is not a big issue.
Yeah. But generally, if the left main lesion is very critical, it is better to address first the left main lesion and make it stabler and before going on to the distal.
50. This is a live case. There is a lot of teaching happening. So I don't want to do a stenting in the distal part of a lady. I usually do always the proximal stent first and distal stent second. Basically, because your stent sizing will not be correct if you take a distal stent first and proximal stent later. Otherwise, you should be so accurate in doing that. I don't know whether it is usual. My trend, even for the CT also, I do like this.
No, that is when you suspect underfilled vessel and then probably spasm, things like that. That applies it to CTOs and very critical lesions. If the lesion proximal in the left main is not very critical, then it shouldn't be mattering. But anyway, the other reason you have is the edge dissection part of it. You can go ahead.
Okay, just give me a 3 mm balloon. We are 3.5.
So the plan is to put a stent in the LCX from the ostium protrusion and put a balloon in the left main to LED. Correct. And then crush it first after the inflation of stent. Correct. Is it? So DK crush following. Okay. Other thing I feel, again, don't think Pratap, same thing I'm telling again and again, the lesion of the LCX is very focalized only in the ostium LCX. Again, most of the times, the stent struts of the left main vessel to LED, like a provisional strategy, it will cover up the ostial lesion of LCX also, even if there's a mild dissection in the ostium of LCX. That's how provisional always works out better. Here LCX, though you had some disease mild maybe in the ostium, distally it looked okay again. So that's another reason why provisional also could have worked. But anyway, I have decided we'll proceed.
That is true. So Srinivas, one problem what I'm telling is actually when you do a provisional stenting, you are landing up either with a tap stenting and otherwise cool out. You will be not getting the result like DK crush. That is what is my worry.
Okay, what is the stent you have taken?
Onyx stent actually 3.5 into 15 into the LMCA, and we've taken a 3.5 mm balloon into the LMCA to LED.
Okay.
Actually, we will go to the lower caudal and see the positioning is correct or not. We will keep 1 or 2 stents start into the LMCA. This is a 3.5 mm balloon into the LED, LMCA to LED, and stent of 3.5 into 15 Onyx. Because I choose Onyx, basically, that Onyx is a very good stent in LMCA lesions because that is a excellent. You can actually go in a very, very high pressure and open it without any big problems in the stent. One cine we are going to take.
And the differential expansion capacity of Onyx without distortion of the distal anatomy is also advantage.
Very, very, and moreover, crossing over is also very, very easy.
That's the advantage of Onyx is that even crossover is pretty smooth and straight and easier than these things.
Right, just come back to our record.
I see Dr. Nikhil. Any comments, Dr. Nikhil, there?
Small check.
Yes, I agree with Pratap's description of choice of Onyx here, because the expansion capacity number one, and the open cell design vascular crossing actually is facilitated by open cell design, and your path becomes that much easier. I'm in agreement with that, yes.
The only advantage of Zion's platform is you can position it exactly at the ostium if you want it, because the markers and the stents start together.
Can you just see that?
You're crushing it, it doesn't really matter.
No, just can look at the, when you inflate, you can see that there is a tight disease by angiographically. When you just inflate, you can see there is a real give.
Yeah.
Probably that stands with me, my suggestion of two-stent strategy, approximate in advantage. Now, next shot, I think. That this you can see.
Yeah, there is an indentation, agreed.
Very indentation. Actually, if you do a nano crush, actually you have to take the balloon that's like this and dilate together. This is actually DK nano crush. Some people apply it. We can do that, and we can take the balloon down like a tap stenting. You take the balloon back and dilate together with a normal atmosphere 10 both. Deflate. Then we will take out the balloon. Now we will take both the wire as well as the balloon. Then one more inflation. Now crushing, that is the first. Yeah. 18. Deflate. In this case, actually, the first case is actually with the same balloon first, and we are without recrossing. You can now take the stent directly. That's advantage. One step is taken off, and that will be easy for an operator as well as for the people. Now we'll be taking a 4x22 stent, which is again measured by OCT. Again, we are taking a Onyx. We can even take a 4.5, but we are taking a 4 stent. 4x24. 26. Because we measured 23, so we are taking a 26 stent. And covering from the ostium, I don't know, many people will have a different opinion, but I usually cover from the ostium.
You measured it from ostium? From the ostium it was 26?
Yeah, this ostium is not diseased. There are 3 millimeters away from the ostium is not diseased, but I am decided to cover up to the ostium. Usually people may stand up in the midway between the LMCA ostium and the shaft, and you can start from the middle part of the LMCA, but I decided to start from the ostium.
If it's coming very close to the ostium, you have no choice like this. Only 3 mm is free. But if a long portion of left main is free, only the disease is there at bifurcation, sometimes you can get away by not addressing the ostium too. Here it is coming very close to the ostium, 3 millimeters only is free, then you are left with no choice. It also helps in performing DK crush, having adequate length of stent in the left main.
Go.
The elevocranial is also best view to see whether ostium of left main is covered or not, Pratap.
It's already deployed.
For you, it is no problem. For beginners, I think you also check in the cranial, elevocranial view ostium, because sometimes...
For everybody, it is important, for everybody, it is important. I did not check it. That was a wrong message, actually, I have given. I should have gone to elevocranial and shallow cranial and see that whether the ostium is covered well or not. That's very, very important.
Generally, the why people who recommend avoiding the ostiums are whenever ostium you're covering, we need to protrude the stent little more into the aorta. So there you need to be extra careful during that part. And however best you do it, ostium always has a little higher chance of restenosis compared to the body because of circular fibers there in the ostium. So that is why if you can avoid ostium, people prefer avoiding ostium. But if the disease is too close, anyway you can't avoid it, it will dissect again, you need to put another stent there. So you need to decide right. But if you are absolutely sure that ostium is not involved, there is a good amount of space, then there is some advantage by leaving the ostium. In general, for any osteal disease is the same.
Srinivas, if there is no osteal disease, then I think you can come back to the ostium very safely, not an issue. If you have an osteal disease, then getting expansion could be an issue, the way you're saying. So if you are 2-3 millimeters away, always come back to the ostium, and I think it will always help.
This is Hemant, sir?
Yeah,
yes.
Okay, sir. The sound and the specific ostium language is made only by you, sir.
You're just a few millimeters away, and I think it makes sense because you can take in any balloon.
Yes, sir. I don't think it is a
bigger than 5.
Oh, good.
Just a small point for ostium, sir. This is Dr. Ajay Swami. I wonder if I might make. Sometimes if you bring the stent right back to the ostium, the guide heating deforms the ostium of the stent. Another reason why some people like to land a millimeter or 2 inside if it's healthy.
The Pratap won't do it anyway. Don't worry.
Don't worry about recrossing. I don't know. But let me see. Actually, we have to do a port and then recross. That is ideal step. You give me a 4 millimeter balloon.
Other time where it happens more is when you do a kissing balloon and trying to get the balloon back, the guide tends to get sucked in and it damages the osteal location of the stent.
Actually, my catheter is inside the stent now.
In the Excel and Noble, sir, the single largest reason for the long-term, one of the important reasons for the long-term bad outcomes was the use of an 8 French guide and the left main stent coming up to the ostium. Because it would, whenever they would try to hook it, it would actually deform, and most of the time it was missed. That is the reason why some people give for.
Yes, very interesting idea. But if you look at SJ Park's group, they have a mandatory requirement that whenever they do the left main procedures, they always use primary and always use 8 French catheters. Very interesting.
Yes, sir, but I'm just sharing the data that came from the Excel and the Noble trial.
Actually,
I agree with you. I never read French. Anyway.
Yes. Old France people all proposed bigger size and covering throughout the ostium. But later on, after late, people are avoiding ostium also.
Pratap, what is the length of your pot?
12 millimeter taken. Actually, it was a 12 millimeter. 14 millimeter was their LMCA. So I took a 12. But what I did is actually I kept the balloon exactly the distal marker was at the carina.
Yeah.
So the distal most part was not a problem. So after this, we are going to take a recrossing wire. The same wire which I used in the first one.
Pratap, it is also important for learning. You need to address how to position that part.
Well, I have shown it. Basically, that time the discussion was going on.
No, you just mentioned that.
Can you just, this is the position. You just see the positioning.
Yeah.
The distal marker of the balloon actually was the exactly at the carina, but the distal most extension beyond that is not a big issue.
Yeah.
So what was the proximal left main size and what was the balloon size for port?
4.74. We took a 4 millimeter only we have taken, but the final we will take a 4.45 millimeter.
So Nikhil, I did not understand your point. Why 8 French guide be better than 7 French for left main?
No, I'm not saying it's better because I'm using 8 French guide. I'm just making a point that SJ Park group probably need 8 French in contrast.
Crossed in 1 minute. You saw the crossing?
Unfortunately, we couldn't, but yeah, I know that you are.
No, you just see that.
Yeah. That's good. Yeah.
And I took.
You have shown all this important thing. What I wish is probably the other tower case at Jaipur is waiting. We'll go there and come back and see your final.
No problem.
Huh?
Okay. Thank you.
And we'll come back to you last 10 minutes again.
No problem. I will come back and I will be ready with the imaging.
Yeah. Okay. I think can you switch to Jaipur, to Eternal Heart Center? Dr. Ravindra Rao is waiting to show the tower case. Unfortunately, the patient of tower turned out to be COVID positive this morning, I was told. So hospital policy as and in general also what is right for the patient is right. So we plan to show a live in a box case of TAVR in a biodegenerative prosthetic valve. Can somebody switch over to Jaipur, please? Achha?
Easily crossed. This is the advantage of the Onyx tent.
Advantage of Pratap also.
No. And almost, I think it's just like that. Wire also crossed, everything crossed. I think you can go to Jaipur and come back.
Yeah.
Go. 18th. We'll take a kissing inflation now. Just give me 3.5 alone for the...
Sir, we are not able to see. You connected Jaipur to our hall or what? Please get Jaipur in the arena 1. Is on? No, we are not able to. No, we still see Pratap here.
No, we can see Jaipur. Yes.
No. Okay.
Just show.
I think now they're connecting. Now they're connecting. Connected.
We can see him, sir. You can pin his video. Dr. Ravinder, hello.
Hello. 1 minute.
3.5 and 4.
Ravinder, we can see you now. Go ahead.
Good afternoon, sir. Can you hear me?
Yeah, we can see you and hear you. Go ahead.
Including I can hear you.
You want it to be cut
Okay.
off. Don't send the feeder to Babu. Disconnect Pratap here.
Yeah,
Disturbing to him.
Yeah, if I disturb Dr. Pratap, I think you can.
No problem. Go ahead. Please.
So, good evening from Jaipur. And at the outset, I would like to thank Dr. Srinivas Kumar for this opportunity to present a live case of TAVR. Unfortunately, the patient got admitted, had first COVID report which was negative and a second COVID report which was positive. We sent a third report also hoping that it will turn out to be negative, but that was positive again. So as a policy, and I think we decided not to do a case on a asymptomatic COVID positive. But I have a very similar case, which is a valve-in-valve TAVR, 73-year-old patient, history of had 19 millimeter pericardial valve replacement done in 2015, presented with severe bioprosthetic valve degeneration, hypertensive, diabetic, COPD. This is the CT scan analysis. Can you hear me? Hello?
Yeah, we can hear you. Go ahead.
Okay. This is a CT scan analysis of the annulus where the perimeter is 52.6. The sinus of valsalva diameter is 29.5, 25. Sinus of valsalva height is good. But the left coronary ostia is 9.1. But look at the diameter of the left coronary cusp, sinus, which is 29.5. Good size femoral vessels for an evolute R using an inline sheath. The vessel size which you need minimum is 5 millimeter. But this is the most important dimension which you need for a valve-in-valve TAVR, which is a valve to coronary distance, VTC. So any VTC which is less than 4 mm increases the risk of coronary obstruction. And how is VTC calculated is by putting using a 3-Mensio software, and you put the size a virtual valve of the size which the patient needs, and from that frame you calculate the distance to coronary height. So you see the VTC for the left coronary artery is 8.3 mm, the VTC for the right coronary artery is 12.3 mm. So the chances of coronary occlusion due to the tissue valve is very remote. So the plan is TF TAVR, 23 mm evolute R, 1 ProGlide, 1 AngioSeal, conscious sedation TAVR, and also procedural optimization. The challenge in this patient is actually the 19 mm tissue valve. So in order to do a TAVR inside a 19 mm tissue valve, we need to have a proper selection of the valve. A balloon expandable intraannular valve will not work. Self-expandable with supraannular design implanted at the right depth can only work in such patients, because if you put an implant, if you put a annular valve, the gradients are high. So this is the fluoroscopic picture, and then We take a 6 French artery on the left side, a 6 French vein on the left side. You see the whole team out here, and you see the Metron Evolute R people behind loading the valve. So what I'll do, because in the interest of time, I'll try to fast forward and just play the important videos here. This is the aortogram where you try to define the outline of the tissue valve, and you need to identify your plane in which the valve will be implanted. This is an AL1 catheter, and you can see how the catheter moves, which actually tells you that you are in the jet of the orifice. But then sometimes the crossing a tissue valve can be challenged because the opening can be very, very eccentric due to fusion or calcification of the leaflets. So here we are trying to cross with an AL2 catheter and a straight tip thermo wire. So after multiple attempts, you go ahead and cross this thing, and then you put in a normal exchange length wire. And then over a normal exchange length wire, a 5 French or a 6 French pigtail goes, and then we do a hemodynamic assessment. This is very important. The challenge in this particular patient was a very small LV cavity. So how do you know it's a very small LV cavity? One, by the echo, second, by the CT scan, but also in the fluoroscopy. If your pigtail is far away from the cardiac silhouette, and when you try to push, it doesn't go any further. And you can also confirm on the echo, which tells you that the patient has a concentric LVH. And you can see the gradient here, peak to peak gradient, which is 254 from the LV and 125 from the aorta. It clearly shows a very severe critical degeneration of the bioprosthetic valve. The next step is you put the confida wire inside the LV over a pigtail. Now, the important discussion which comes here, should you pre-dilate a tissue valve or not? So in my practice, I don't do any pre-dilatation of a tissue valve. There are two reasons. One is you can tear the leaflet, and that can cause torrential AR. And patients who have concentric LVH and small LV cavity, as soon as you create AR, they develop hemodynamic compromise. Now you see we are removing the 14 French sheath from the groin, and the confida wire is parked in the LV. So very important, you need to keep a focus on that wire, because one of the risk factors for an LV perforation is concentric LVH, small LV cavity, female sex, and elderly patients. Now the inline sheath will go. Dr. Srinivas, sir, just let me know if I have to stop, because I thought I was just talking and talking. So if you want to have any particular discussion at any point of time.
Please go ahead.
Yeah, so this is the valve which goes in using the inline sheath. As I said, so if you use an inline sheath, the vessel size which you just need is 5 millimeter, or if it is a calcified vessel, even through a 5.5 can be used, but not the Pro, because Pro is goes through a 16 French sheath. So once you do this, you go ahead and, as I'm doing, you can see my hand, you watch under fluoro how the valve goes or enters the pelvic vessels, but you also keep a focus on the wire in the LV. Once that is done, you hold the inline sheath and just advance the valve through the valve. And now the focus will be on fluoroscopy. And then you go LAO and you want to see how the valve goes across the arch. And now this is the important step. You go ahead and cross the valve. Sometimes the crossing can be a challenge, because as you saw, the nose cone can hit the frame of the tissue valve. So the most important thing when you are doing a valve-in-valve inside a smaller bioprosthetic valve, remember this valve is just 19 millimeter. You don't want to leave a patient processes mismatch. And the way to do is you try to implant this valve as high as possible, but you should have enough room that if you do a post dilatation, that is, you want to crack the frame, you can comfortably do it. So now you see this ring which is there at the lowermost part, this ring does not coincide with the lowermost end of the crimped valve. That's very important. So you go caudal, remove the parallax in the ring, make it into a straight line. And then the important challenge in this patient, as I said, is a concentric LV hypertrophy, very small LV cavity. So in such patients, if these patients develop hypotension, you give them fluids, you give them almost 500 ml to 1 liter of fluid, because if you increase the dose of inotropes and the ventricle is empty, there is a high chance that the valve will pop out. So at this point, when the valve is about to make a contact, we go ahead and pace the heart at 180, but you saw how the valve just popped out. And if you look at the depth was not very shallow, so we were almost appropriate. See here? And the frame is not touching the bioprosthetic frame, and that is because of the pannus which is present between these two frames. And this popping out was because, as I said, a small LV cavity and hypercontractile LV. So you recapture this thing, and then you go again. So when the valve pops out, you do a full recapture. You see, you do a full recapture, and then you make sure that the nose cone and the sheath, they are in approximation, and then you go ahead and cross again. So valve-in-valve TAVR also increases the risk of stroke in such patients. And then this is what we accepted. The reason I accepted this depth is, remember, this is a 19 millimeter valve, and we need to do an aggressive post-dilation in this patient. Once that is done, you go ahead and release the frame, and now removing the nose cone will be very challenging. So see, the frame, the valve frame is not in full opposition with the tissue valve, and that is because of the pannus. So if the nose cone catches onto the lower end of the valve, it can pop out. So what you do is you pull back the wire, centralize the nose cone, recapture the nose cone, and then you do a hemodynamic assessment. So in a 19 mm valve-in-valve, whatever the hemodynamics show, I would always do a post-dilatation. Now suppose if I'm not able to fracture the frame, what it will do, at least it will optimize the results by approximating the frame to the tissue valve. So what size? Yes.
We thought that if a bioprosthetic valve is of less than 21, always it is better to crack it because of residual gradients could be high. If it is a big bioprosthetic valve like 23, 25, no problem. But generally 19 valve, you said. 19 valve, now recommendation is you have to dilate, crack it before you take the valve.
No, sir. There is. You have to do you have to crack the frame, but there is no such recommendation that you should do before TAVR, before putting the TAVR. The challenge is if you do pre-dilatation of a tissue valve, there is a high chance that the tissue leaflet will tear, and patient can have a torrential AR and hemodynamic compromise. The second complication which can happen is the leaflet material can tear and cause a stroke. So if I have to do any pre-dilatation, I'm just imagining, I would not do without using a cerebral protection. But if I put my TAVR valve inside this tissue valve, and now if I have to do a post-dilatation, the leaflets are protected, there is no chance of any severe AR, there is no chance of, less chance of having a stroke.
So you're okay till what sized valve of a bioprosthetic valve doing the TAVR later? In 19 is okay for you?
Yes, so 19 is okay, but remember there are not all valves can be post-dilated. So important thing which I have to see in such patients is the body surface area. So if my patient is very obese, say my patient is 68-year-old, weight is 100 kilogram, and now surgeon has put a 19 mm valve, I might not do a TAVR in that patient. I might ask the surgeon to do a root enlargement and put a 21 or a 23. Because the patient processes mismatch also depends on the body surface area of the patient. But if my patient is an elderly, lean and thin, 60 kilogram female, I would just go ahead and do a TAVR in such patients. But the valve which you have to use is a supraannular evolute R valve in such patients. So now you see this is the post-dilatation setup which we are doing, which is used to crack the frame. So you use an inflation device, a 3-way cannula, and a 50 cc Luer lock syringe, and connect it to the side. The balloon which can be used for post-dilatation can be any, but balloon which you want to use to crack the frame is an Atlas Gold balloon or a True Balloon, Loma Vista True Balloon from Bard Life Sciences. The True Balloon is not available in India, but Atlas Gold is available. But I'm going to show you the challenge which we faced with an Atlas Gold. It deflates very slowly. So we decided to use a ZMED balloon. So this is a 19 mm valve. I used a 20 mm balloon.
And the contrast also should be more, I think. You dilute the contrast more so that the more viscosity is less, so that better to
Yes,
deflate.
so the dilution in such condition is 1:5. But the balloon material, the Atlas Gold balloon material was such that it would deflate and inflate very slowly. And that is not actually advisable in an aortic position. You can use it for a pulmonary position or for an aorta, but not for an aortic valve in valve, because you're going to rapidly pace for a few seconds and then even post dilatation. So this is just steps how to do negative, because that's very important. If this balloon ruptures at the annulus and there is a lot of air in the system, you can have even air embolism to the coronaries, but most importantly, the air can also go to the cerebral circulation, and that can be a disaster. So I will go to the next. I'll fast forward a little so that we just see the balloon dilatation, how it is done, because positioning of the balloon is also very important.
If you don't position it right, it always tends to pop up. If you position it deep, it tends to damage the LVOT. And we had one problem of when you're dilating, one patient developed the problem of, this is unusual described, you produced a VSD below it.
Yes.
And then patient had some trouble. We had to close it with the device later.
Yes. Was the VSD, so there are two complications which can happen. So you can have a Garbode defect also, because the membranous septum is there. You can have a connection from LV to RA. You can also, so look at the dilatation. This is how you have to do. The balloon has to protrude into the LVOT. And the reason is, by doing this step, you are not causing much damage to the TAVR valve leaflets. So the TAVR valve leaflets are almost 13 mm above the lowermost end of the valve frame. But what happened is, when we tried to crack this valve, you see the prolonged inflation, patient developed, hypoxia to the brain and just 1 or 2 few seconds of convulsion, but he immediately recovered. So this was just an optimization, and then post-procedure, the gradient, the peak-to-peak gradient on invasive hemodynamics was just 10 millimeters of mercury, and we accepted this result. So if your mean gradient is less than 10 in a valve-in-valve patients, that is an acceptable result, and then you don't try to use a bigger balloon to crack it. So the balloon recommended is just one size bigger than the size of the tissue valve.
I think Ravinder, excellent demonstration. Initially, when you were doing it, we felt it could be more problematic, but positioning it in a bioprosthetic valve, if you do it right and selecting the right size valve, I thought it is okay, reasonably better, less complicated than doing a native valve. But only thing is, you should know which size of valve to use. You have that app which you select it, and select it right, I think you can do well. You've shown it very well. And one more point you mentioned is little acceptable gradients are also fine if it is a narrow annulus. All that point is very important. Otherwise, you keep on dilating, you produce into more problem. And we need to, any final words, Ravinder, we need to break from you. And Ajay or anybody has anything to say before we break to go to Pratap last? Anything, because the final thing is you're checking the groin. That is important. You also show
Yes. Okay. So, I mean, the only thing which I want to tell you new is nowadays I use one angioseal and one ProGlide. But I think in the interest of time, I'm not going to go into detail. But this is the final picture where you don't see any pinching of a vessel if you use one ProGlide and one angioseal, which I also showed in India Live. But, thank you very much, sir, again. And thank you all the audiences for...
Thank you. Thank you, Ravinder. Excellent demonstration. Hope we would have either had a live, but because of COVID situation, at least we could have this. Thanks for accepting to it.
Thank you, sir. Thank you. Thank you all, and thank you all the audiences for joining.
I'm happy to say that about 1450 doctors have watched you this online in this thing. There is another simultaneous program also going in the arena too. Good. Thank you. Just can you get Pratap online for some time before we close the live case? Because we wanted to see the final result of Pratap. Archita? Yeah, Pratap, we are with you now. We are not able to hear him. Pratap? Ujjwal, can you correct Pratap's audio, please? Audio input is not there. But we can see you, Pratap. Your mic is on mute, I believe, Pratap. You have to tell your people to unmute the mic. Yeah, we can hear you now. It's again gone. Yeah, that's what initially sound came from the lab. I thought it was unmuted.
Somebody can pull me directly, please.
Can you unmute Pratap's mic, please? చెప్పమ్మా.
Stalin can talk.
Hello, sir. Can you hear me? Dr. Stalin from Kollam.
We can hear you. Go ahead.
Hi, yes, sir.
Go ahead.
Now we can see the high pressure balloon inflation at the sarcosteum.
Next.
Next step is the.
We are taking two balloons, one into the circumflex, one into the LAD. This is actually a balloon 3.5, high pressure dilatation. 4 millimeter balloon in the LAD, again high pressure. This is a simultaneous inflation, simultaneous deflation. We are actually taken, this is actually the pot we are taking, 4.5 millimeter balloon. Just see the positioning of the pot. I don't know whether you are hearing or not.
Yeah, we are able to hear you now.
Yeah. It is balloon inflation, very high pressure. Then now we are actually taken, this is OCT. Can you show the OCT now? Okay, can you change over the OCT?
Yeah.
OCT. Okay. Can you show, Stalin, can you explain?
Yeah, we can see the OCT run from distal to proximal. Here in the distal area, not much of plaque here, but the lumen size is very narrow. Now we are coming to the middle lesion. What we saw initially quite significant doesn't look that bad now. Yeah. Now the lady size is becoming bigger.
Our worry was there's no edge dissection.
There is no edge dissection.
That's an important place to look at carefully the OCT. I think it's clear for dissection.
Yeah,
okay.
Very
no
clear.
edge dissection.
Yeah.
And again, proximally, stent is well expanded and a post.
That's L6 ostium?
Yeah, now we are coming to the ostium. This is the osteal we got an area of 8.45.
8.45 is the osteal area.
Yeah.
Okay.
And LMC.
This is the POC. POC areas again, it's very big. It's 14.
14 is the POC.
And also the stent is well opposed and expanded in the LMCA.
LMCA, how much is the area?
LMC area is 15, 16.
15.12.
15 to 16 throughout.
We did
Yeah. Now we'll go to the L6 pullback.
We did not take any injection in between. Only one.
Ideally, L6 pull back, Pratap, but even in this frame also, sometimes you rotate it, the L6 ostium can be seen. Anyway, you're doing L6, stent is there, you're pulling back, that is the best. But if you're not doing that also, sometimes you see the osteum.
Correct.
Yeah, we tried, but we couldn't get a clear image in the bifurcation mode. So we,
that is why.
so we took a separate L6 run also.
Okay.
Again, here there is no dissection. And
perfect.
Some artifacts here, but overall well expanded and opposed stent.
Ostium,
Yeah, now we're coming towards ostium. This is ostial part.
Ostium is
Around 6.5, 6.4. Again, it's okay.
6.46 by OCT is definitely more in IVS, right?
Yeah, but anyway, the one point is very clear because when we protruded the stent adequately, there is no area without a stent strut. That is clear. And then reasonable areas you achieved.
You can see the opening of the sarcostium and very well seen. Can you just?
Yeah, this is the LAD opening, and there is throat strut coverage. So there is no uncovered strut. And also there is no residual carina, neocarina. So exactly the second crossing was through the distal struts. So no neocarina.
I think
only problem is if you see it, however best you do, distal portion of LCX looks slightly bigger than the exact ostial location of LCX. This is a challenge, but what area you got is always okay. I think finally you can accept this result and you did a good job. Great. And can you show the final one angiographic picture to everybody?
Angio picture. Right? No, I will take an angio picture.
Yeah.
No, I will do. No. Okay. Ready?
Yeah, perfect, Pratap. You left main work, you did well, and you can work coolly regarding the middle area, whatever you want to do.
Thank you very much, Srinivas. Thank you very much, Shiva, and very much, sir. Thank you.
Thank you. Great job, Pratap.
I do always CTO. This time I decided to do a LMCA.
Yeah, good.
Thank you. Because Shiva was sitting there. That is why I decided to do LMCA.
Great. Thank you. And
thank you very much.
Thank you, Pratap. Can you cut the feeding for Pratap? We'll go to the next session. Again, as told before, it's always good to join back in the same session to avoid this switching over time waste what we face in the first day. I think we have all the chairpersons and the speakers of the next session. It is on congenital heart disease and other structural interventions. We have my good friend, Dr. K. Nageshwar Rao, DD login. He's there, I can see you. We thought we would show you more attractive in this room, like where I'm sitting, but it couldn't happen because of various our hospital problems. And then Dr. Nageshwar Rao and Dr. Shiva will be conducting Shiv Kumar. Again, thank you, Shiva, for joining. And I can see him. Then sorry for slight delay. What I promised Nageshwar Rao is Dr. Sachin, he has some commitment. So whatever exact time we mentioned for Sachin, sir, from 5 to 5:15, let us allow his talk. The rest of it, I leave it to you to adjust. Okay? Over to you, Dr. Nageshwar Rao. Can you hear me?
Thank you very much, Dr. Srinivas Kumar. It's indeed a great pleasure to be part of your TCT program going on for the past 10 years. And we are happy to be part of this program. So today's panelists and chairpersons, Dr. Radhakrishna, I think he is not available. So I request Dr. Shiv Kumar to take the chair, and other panelists, Dr. Saurabh Gupta, Dr. Jay Ranganath, Dr. Srinivas, Dr. Sunita Vishwanathan, Dr. Tasin, Dr. Gaurav, Dr. Rajiv Rajput, Dr. Rishi Kumar Gupta, Dr. Suman Bandari, Dr. Vishal. I welcome all of you, and I request Shiv Kumar to start the session. Please introduce Dr. Krishna Kumar, and then subsequently we can carry on with the further proceedings. Please unmute Shiv Kumar.
Hello. Thank you, Nageshwar. It's a pleasure to be part of this meeting. I'm seeing Dr. Krishna Kumar waiting for quite some time. Dr. Krishna Kumar is one of the very senior pediatric cardiology members, and he has mentored hundreds of other pediatric cardiologists throughout the country. We look forward to hear from him.
Dr. Saurabh is the panelist, and Dr. Jay Ranganath, you can probably interact the questions from the audience, or you can moderate the session in between also.
Nageshwar, I'm having some challenge in sharing my screen. It doesn't show the PowerPoint in the list of things that I can share in Zoom. I've been trying for quite some time.
Is it possible for there might be a screen sharing enabling switch that will allow me to share my screen, because I don't seem to be seeing PowerPoint in the list of files that I can share. Of course, Saurabh is the Zoom expert. He can guide us also.
First, you open the PowerPoint slides, and then you go to.
Yeah, it's all been opened for quite some time. I've been doing Zooms for a long time, but today it's been very stubbornly refusing to allow me to share the screen. I don't know why. Have you enabled my screen sharing? Was it disabled in the first place? I actually disconnected and reconnected also with the hope that I would, but even that didn't work. So I'm not sure why I'm not able to share screen. One of those glitches.
Sir, I think share screen is enabled, sir. If I click on mine, it is allowing, sir.
Yeah, it's enabled, and well, for some reason, in the list of files that I can share, it just lets me share my, it doesn't let me share what I want to share.
Sir, you share your desktop screen, and then you click on PowerPoint maybe.
I'll do that. So I'm sharing my desktop. It says share desktop screen. I'm sharing that. So I'm clicked on that, and I'm going to click on PowerPoint now.
Yes, sir. Just go down.
Can you see that now?
Yeah, we can see that. We can
fantastic. Okay, that's fantastic.
Thank you.
So I've been asked to talk about the 3 most important innovations in pediatric cardiology. And I'll try and do this as quickly as possible, recognizing that we are behind schedule. I've made this timeline of innovations which are pertinent to pediatric catheter interventions. And there are some unsung heroes that it's very difficult to document because you don't have those publications. But what's traditionally accepted is the balloon atrial septostomy in the late 60s, Postman's PDA closure, and I couldn't find a picture of him in the internet, but the PDA plug that was very, very innovative, and that happened in the late 60s, early 70s. Terry King, who made the first ASD device in the mid 70s, and it was a remarkable innovation at that time. Jean Kahn, who did the first pulmonary balloon valvuloplasty in the early 80s. So her paper appeared in the NEJM in 1982. Jim Locke, who was my mentor, who's had a whole host of innovations to his name, but perhaps the ones that really mattered at that time was the mitral stenosis and the VSD closure. Of course, he did the first coarct dilatation as well, and he went on to innovate, and even as late as a few years ago, he made the innovated a needle for fetal interventions. Chuck Mullins should get maximum credit for having put stents in the pediatric cardiac armamentarium. And I think he has done more for that than anybody else. Kurt Amplards came up with the whole Amplards family of devices, which has transformed our lives. And then, of course, Philippe Bonhoeffer. So this is the kind of timeline we are all familiar with. And all of them were extraordinary innovations in pediatric catheter interventions. But I think you need to go a little deeper. And it's important to recognize that what really has enabled these interventions. So we often just are identifying individuals who have been associated with products. So firstly, it's all this background science that has been very essential for people to innovate within that framework. But more importantly, there has been some very important enabling technology, which is imaging, the cath lab technology, the hardware, intensive care, pediatric cardiac surgery, and then material science, which is all very, very important, particularly more recently, the nitinol alloy and a variety of other developments in material science. So all this has been sort of the enabling influence that has set the stage for the innovations that we want to talk about. And of course, we go on listing, this is a list of top 25 innovations that I was asked to list for the previous World Congress by Gil Vanofsky.
And I listed some of these, very extraordinary innovations inventions or contributions or developments that we are all familiar with. And we've marked out with red the ones that I talked to you about, some of the ones, which is the valvuloplasty, the Amplatz family of devices, and Bonhoeffer valve. Now, that's really not the point of what I'm talking about. I want to come to the point of what do we do to choose as top three. I think we have this whole tendency of pointing or assigning individuals to inventions. And we think that it stems from this whole notion that people who really think out of the box have done something extraordinary, and they're crazy to think that they can change the world. So these are the guys who really are making the difference. So we have to choose maybe the ones which are most impactful in terms of numbers that have, patient numbers, most ingenious ones, most challenging circumstances. What do we choose? I think there are some serious fallacies here. We give too much importance to specific individuals. We try to assign individuals to inventions and say that these guys made the difference. That's not true. When the time is ripe, someone or the other will come up with the innovation. It's only a matter of time. It's so many things that happen to enable these processes. Now, I think we have this illusion that individuals change the world. And these are very great individuals. Who we say that made all the difference. We ascribe our freedom to Mahatma Gandhi. We say that end of apartheid was because of Nelson Mandela. We say Einstein, relativity happened entirely because of Einstein. And we say that today's smartphones are because of Steve Jobs. Now, I can tell you, if you think in this fashion, actually it's because we love to posit every individual. For every global development, we want to assign a human being. We posit a human being into existence. And this is an illusion. I think the notion that an individual can change the world is one of the greatest ideologies of the century, but it's also the grandest of illusions. Because when the time is ripe, if it were not for Gandhi, it would have been somebody else. It would have still happened because there's so many events taking place, but we have a cognitive bias in trying to put our finger on one person and then assigning everything to that person. Give you two more stories to illustrate it more dramatically. Now, who are these two guys? This is Alexander Graham Bell and Thomas Alva Edison. Great inventors. Graham Bell invented the telephone and Edison invented the electric bulb. Now, do you know that there were 23 other inventors at Edison's time who were on the threshold of making the bulb? For that matter, Wright brothers, so many other people who made these inventions, there were so many others at the same time trying to do this. But the story of Graham Bell is even more interesting because there was another guy and his name was Elisha Gray. Both actually invented the telephone at the same time. And both were actually traveling to the patent office on the same day. But Elisha Gray got run over by a horse cart and died. And Graham Bell, that's history. So technology will find its inventors and not the vice versa. It's not the other way around. And this is important to realize in our own field, more so than all these famous historic events. Science and technologies advance in baby steps through cumulative efforts of numerous individuals. Many unsung heroes never get the credit they deserve. And most current knowledge sources have a distinct Western bias. I can happily say this. We don't. I know even if there were Westerners sitting in the audience, I would have said it. Dr. Locke's paper on mitral balloon got into New England Journal of Medicine. Whereas at the same time, there was another gentleman who made a far more innovative product. You think of every aspect of the inner balloon. You think of the extent of innovation and thought involved in making this balloon way back in the early 80s. Inau was a cardiac surgeon who, I don't think there is any parallel to the extent of innovation in this,
in anything else that we do. It's a remarkable piece of invention and thought that actually makes mitral balloons so easy. Yet, he is mentioned, and it was a while before got famous or got what he was due. For many years, the first balloon mitral procedure was ascribed to somebody else, and he was never given a credit. I'm going to come closer home. I'm going to come to another person I truly admire, Dr. George Joseph. Now, he made the Jomiva balloon because he found that the inner balloon was way too expensive. So he put a lot of thought, and what looks really simple actually had a lot of thought behind it as to how we should design such a balloon which could inflate rapidly, which could deflate rapidly, which had a very short tapering tip, lots of issues that were thought about, and then went ahead and did 1,400 consecutive balloon mitral valvotomies through a jugular approach as well. But he never got a credit. This is Journal of Invasive Cardiology. You may have hardly heard of this journal. So, and we as Indians did very little to promote this product, which could have actually made a real difference to the cost of the procedure. We did not. We were so colonized by our Western the way we've been conditioned that we actually did not even promote this balloon. So it's unfortunate, but that's the way it is. And this balloon hasn't really gotten its due. Now, here's somebody that I know personally. He was 3 years my senior in All India Institute, a brilliant mind, Dr. Gladwin Das. Now, Gladwin Das actually worked with Kurt Amplart's lab. Until the mid-90s, all the ASD devices had a central point of contact, which was just at one point. As a result, the devices had to be twice the size of the atrial septal defects. All the devices of that generation were a big challenge. Clamshell device, Sidris device, everything would be a real problem to do, and the vast majority of ASDs would be unsuitable. So Gladwin came up with this whole thought of a self-centering device. Now, he didn't do the other elements right in this design, but he sat in Dr. Amplart's lab and came up with the concept of self-centering ASD device. Now, that concept actually translated with a nitinol mesh into what you see today. But Gladwin is unheard of, unsung, and nobody knows about him. So it's important to recognize that we tend to give too much importance. Now, other important thing I want to tell you is there is a very big difference between West and the East when it comes to this whole concept of intellectual ownership. The West, it's very well, there is an obsession as to who owns the idea. In the East, we give it away. So when we look at the greatest Eastern inventions, so here a list of inventions that have happened in China that have been transformative, remarkable. The mechanical, the magnetic compass, the abacus, the paper, the umbrella, the rocket with gunpowder, the kite, the tea, silk, the crossbow, all Chinese inventions. And you can't figure out who actually invented them. Nobody knows. No names. Even in India, we had this tendency that we just had collective knowledge. We didn't give names to it, the people who actually produced that knowledge. So we didn't really care as to who the individual was because we recognized that knowledge cannot be entirely one individual's own creation. It's actually a culmination of a lot of people's efforts. So I think all of us innovate. One way or the other, we are all doing it. It's some of us get credit, some of us gets lucky, some of us actually take it very far, but we're all doing it because our lives are so difficult. And what we have to really think about is how can we innovate to make the maximum impact to the largest number of patients? How can we produce a robust framework within this country to translate ideas into useful products that our patients can afford? And this is something all of us do in our cath labs. We reduce the cost of pediatric heart caths because it's expensive equipment, it has long procedure times, it has low caseload. So we find ways, and we do it every day, every minute of our existence, and we are finding a number of ways to actually adapt. Some of us have actually gone one step further. Nageshwar Rao has actually made a device, the Konar MF device, which is really, we feel very proud of because it's really got worldwide acceptance. And there are other innovations downstream that will happen, hopefully. And this is really important. We have to encourage this kind of work because it needs to come from this part of the world. And we need to make a mark in the manner in which, and give credit to our inventors in the manner in which it's done in the West. But at the same time, I think we need to do this collectively. The point that we have to do, I think that when you innovate, as a personal reflection, I have to say that these are the three elements. I'm sure all of us are cognizant of these three elements, which is the product has to be great, it has to be efficacious, it should be safe, and it should be inexpensive. And I think the cost factor is incredibly important in our context. So the mental toolkit, not everybody can do it. I can tell you that. What makes Dr. Locke very different, what makes Sachin very different, what makes Shaq Qureshi very different is because their foundations are spectacular. Their basics are very good. So you get your foundations right in anatomy and hemodynamics, in material technology, etc. Understand catheter hardware, and always be willing to question conventional wisdom. Do not get straitjacketed by protocols. Think out of the box. And the other thing is, today's mantra is collaboration. We need to work together. We need to have partnerships with the industry. We need to interact with people outside of our comfort zones, of people who are working in other spheres, much more than before. We have been living in silos. We've been living in isolated, insular islands, and we need to change that. And of course, the most important thing, and that we have to persist. When you have a good idea, you have to take it to the very end. And without doubt, we need robust quality improvement systems, a good database, regular introspection of our complications, etc. And then, of course, we have to publish, no matter what happens. So I have to conclude by saying, I cannot identify three most important innovations in pediatric cardiology. Thank you. I'm done.
Thank you, Dr. KK. I was thinking Nageshwar will take over. I think it is possibly going to serve as a motivation for all the youngsters to take up and, as you said, think out of the box and make some real attempt towards making a useful innovation which will be cost effective for the community. And I request my close friend Dr. Nageshwar Rao for his second presentation, Konar MF device, which was the first Indian pediatric occluder device that has been conceptualized by one of our own friends. Over to you, Nageshwar.
Thank you very much, Shiv Kumar, and I enjoyed thoroughly the talk by Dr. Krishna Kumar. There's a lot of insight in that. I do agree with him that there's nothing like one or two. We have a tendency to name it 1 to 10. I think if you look at that various fields in subspecialty of pediatric cardiology itself, including fetal and electrophysiology, there are more innovative approaches. So with that, thank you very much. Thank you, Srinivas Kumar. And today I am going to give some kind of information on the Konar MF device from innovation to clinical practice. These are my disclosures. I must acknowledge one of my mentor, Dr. Raghav Raju, who actually encouraged me during my days at a care hospital to actually look into critically to develop a newer device, and also he actually named the device Konar MF. What is an ideal device? So already KK told that ideal device should be safe first, effective, simple to use by all, reproducible and affordable. And in terms of perimembranous VST, it should not cause a heart block, and it should be used even in smaller babies, younger babies. The delivery system, everything should be user friendly, and all kind of torture circuits, various other structural problems should be effectively addressed by the device. It can be closed from antegrade, retrograde, then only we can call it as an ideal device. So we were having lot of devices, even still we have devices like ADO2, AAS and Occlutech devices, and this is the perimembranous VST second generation, which was withdrawn from the market. This is the eccentric device. All these devices have got their own advantages and various disadvantages by limitation of the size, various sizes, and the disadvantage of having one screw, and the device is very stiffer and very, very short, the retention disc. So what happened after introduction of the eccentric device in mid 2000, that is 2004 to 2005, there was over enthusiasm of closing a lot of perimembranous VSTs, and followed by short-term and medium-term outcomes showed that a significant development of the heart block in these cases. So the published data from the European registry as well as Canadian data showed that the device is causing a serious conduction heart blocks. So that's why most of the centers have withdrawn from that, from doing the VST device closures. So what is actually causing this problem? Number one, if you look at carefully Anderson paper, this is 1960s paper, the conduction system is highly vulnerable and variable in perimembranous defect. It goes inferior posteriorly and divides into right bundle and left bundle. So any kind of stress on the conduction system will cause complete heart block. You look at this published complete heart block, one of the case, the device is so much distorted here. This is because of the oversizing of the device, and the waist is 3 millimeters in eccentric device that causes a lot of impingement on the conduction system leading to the heart block. We understood several of these and found that now, apart from the anatomical location of the defect, type of the device, shear stress by the device, and the clamping force are the major problems which are producing the heart block. And also, some of the cases, some of the devices are having the fabric which is going to be highly inflammatory. The autopsy showed in animals there's a significant inflammation which may be one of the reasons for the heart block. What we worked on this for a long time, we understood, even we have done some electrophysiological study in our department along with Professor Narasimhan. We found that various conduction systems are identified. There are 4 types of conduction systems in perimembranous VST. The right bundle, which is close to the VST, left bundle in case of inlet extension. So all these variables we should find out if you understand it clearly using the 3D mapping system. We also understood to some extent, and also we did some in vitro studies along with the Life Tech company, showed that there are significant shear stress, direct stress, compressive stress, and tensile stress, whatever the device you use it. So irrespective of the device which you are going to deploy in the perimembranous VST is going to produce some kind of a stress. So this is the probable reason for the one of the major reason for the complete heart block. What is the solution? So it happened in 2011 to 13. I was using ADO2 in the perimembranous location and found that the device is very low profile and which is causing a very, very less shear stress or compressive stress on the conduction system. So I met an engineer called Mr. Jog, and he is still working with me, and we shared our problems and we came to understanding to develop a device called multifunctional occluder. It has got incremental rise in the diameter to adjust as per the hemodynamics of the high pressure side, that is left ventricle or aorta side, and it should have both sides deployment of the screws, and screws should not produce very much outside. It should go through the soft small delivery systems. So because of the advantage of the both side the screws, we actually found it is useful both in antegrade technique as well as the retrograde technique. So with that designing and in idea, we actually first developed 4 devices, 4 sizes, that is 5.3 to 8.6 without any fabric, and it should go with 5 or 6 French sheet. So we deployed in China and some other countries after ethics committee approval and found it was very useful. Then in the same year, we thought that 8.6 is going to be very small device. Hence, we came with the idea of producing a bigger devices. But the major problem with that was there was porosity was increased and significant hemolysis was observed. That's why we had to add a membrane, PTFE membrane from 7-9 device onwards. So after that, we developed the cables and did a lot of in vitro studies to check whether device is safe or not. And we found it was very good and safe. And then final product came like this, a cone-shaped device which has got incremental increase in dimensions, and both sides we have a retention screws called Conar MF. So I will show you some of the cases. You can see here a large membranous ventricular septal defects. It's a part of the electrophysiological 3D mapping study which we took. 8.7 millimeter, QP by QS was 2.6 and PVR was normal. So this is the regular, a standard conventional approach what we do, antegrade, forming the arteriovenous looping here and then putting a 6 French sheath through the femoral vein into the left ventricle. So in this particular patient, we actually deployed 1210 Conar MF. This is one of our first largest device which we deployed. That's why I always keep this particular slide case scenario to show it. So there was no residual leak and there was no impingement, and this is the longest patient and we did not find any of the conduction abnormality. Procedure went on very well and smoothly. Then we embarked on different category of approaches in different case scenarios. This is a 6-year-old girl with a QPQS 1.6 and PVR 5, more than 5. There are multiple VSTs. You can see anterior muscular VSTs, mid-muscular VSTs. What we have done, we used our own described method called transeptal antegrade method. We closed 2 and we left 2 of the small VSTs as a pop-off because PVR was high. So these are the 2 devices which deployed. We have done repeat cath after 4 years, that was last year, and showed that PVR became normal and residual VSTs got closed. So I want to give an information that when we have multiple VSTs not amenable for surgery, leaving a residual VSTs and closing the amenable ones is quite a good option in some of the cases. This is another 7-year-old girl, a DORV, multiple VST, normal related great vessel, underwent a pulmonary artery banding to prevent the pulmonary vascular disease. She was planned for surgery, but unfortunately, multiple VSTs, surgeon felt that it's very difficult to approach those things. So what we have done, we did a staged hybrid procedure. We closed 2 of the apical VSTs here, 2 of the apical VSTs, and left a major subaortic VST here. And then subsequently, after a couple of weeks, surgeon closed that VST, routed the VST to aorta. So similarly, other indications, this is an infant of 7 months, 4.5 kilogram, a large AP window. You can see large AP window being closed antegradely, femoral venous approach using the Conar MF 7.5 Conar MF device. So it is possible to close even antegradely or retrogradely tortuous circuits using this particular device because of its medium profile device, and maneuverability is easy and occlusion rates are very high. And this is a recent case I want to share. This is a 25 days old child with a significant VST, mechanical aspiration syndrome, and failed extubation 3 times. The neonatologist requested us to do something. Then we thought that this is ideal case. Myself and my colleague, Dr. Shweta, we actually planned properly and crossed from the right ventricle side, and we used a 5 French Boston modification Mullins sheath here, and then we deployed 86 Konar MF device antegrade. So if you look at the immediate post-operative, post-procedure day 1 echo, there's absolutely no residual leak and device is very well positioned, and this is the pre-discharge X-ray showed very good result, and the child behaved very well, did extremely very well. But the problem was there was a mild tachypnea was there. So we found that because of the dilated left ventricle, there was a diastolic dysfunction, and we started carvedilol. Baby improved very well with the carvedilol treatment in this particular case. So other indications, these are very interesting. We have closed around 3 paravalvular leaks using multiple Konar MFs. Here it's a very easy because you can use the guide catheter and you can go retrogradely. You don't need to even put the transeptal approach in these cases. This is one of the case we had to put 2 Konar MF devices in a mitral paravalvular leak situation. Other iatrogenic complex interventions like this is a post pulmonary root transplant in a DTGA VSTPS. Our surgeon produced a rent here in the patch, and the child was having a heart failure. So we have to close this using a Konar MF here, using a transeptal approach in this particular patient. So this is a very interesting case actually. After that, child did very well, and this is the final result of this particular. We used a bigger device here, 1210 device, because there is no issue of conduction system. It was a bovine patch there which was used. So that's why we oversized a little bit in this particular case. So our experience from 2016 to 2020 showed that we have done 55 cases of ventricular septal defect, of which median age was 4 years, weight was 14 kilograms, and perimembranous VSTs were 44, antemuscular 4, midmuscular 3, and apical muscular was 2. We have done other indications, that is non-ventricular septal defect, other non-conventional indications also. These are the world literature which is available. One of the paper from Lebanon showed very good results, excellent results, and this is the first European paper from the German, and this is the largest series of 98 cases from Turkey showed excellent results. They had one heart block, but that was intentionally, they produced heart block while putting the AV looping. In spite that, the device was deployed. But however, the heart block improved after this. This is from the Argentina. The data showed very good results using the Konar MF. So this recently, I got the information from the German and Poland using Konar MF device in a child with Abernathy malformation. They could successfully close it. To summarize, the new Konar MF appears to be very useful in many situations. It's a medium profile property that is going to be more useful in terms of the hemodynamic adjustment and to prevent to some extent of a heart block. We need to do long-term, we need to see the long-term results, and many institutional experience is going to be important for this device to endorse by everybody. Thank you very much.
Thanks a lot, Nageshwar. That was a wonderful presentation. I'm sure it is going to be applicable in every cardiovascular structural pathology. Any questions? I'm not finding anything on the chat box. So I'm seeing Dr. Sachin Kambatkon waiting for some time, and the time is also 13 minutes behind schedule. Can I request Dr. Sachin Kambatkon to talk about his experience on Melody valve implantation?
Hello, can you hear me?
Sachin, we are able to see your slide.
Yeah, can you hear me?
Yeah, very well. We can hear you very well.
Sorry, I'm running a little bit late, so I will emphasize specific points. Very interesting talks, both by Krishna, KK, and Nageshwara. Very well-known things about pulmonary valve, going back to the innovation part, which KK touched upon. This is the kind of historical timeline. The first aortic valve implantation, which was indeed done by surgery, was actually in the descending aorta to treat severe aortic regurgitation, was done by a surgeon from Georgetown. Charles Hufnagel's design was actually the predecessor for the ball valve type of valves. The concept that at that time still was to try and implant a valve more than a transcatheter approach. And then the biggest leap came with Henning Andersen from Aarhus University in Denmark. And he was an adult cardiologist researching electrophysiology, attending a coronary angioplasty session at a conference. A very interesting interview where he describes how he looked at a 3 millimeter stent being implanted and suddenly thought, why can't it be 10 times larger stent with a valve inside it? He had this idea in 1989 when he attended the conference, and he went its relationship to sudden cardiac death in late repair of tetralogy of Fallot and causing mechanoelectrical interactions with prolonged QRS, contribution from Michael Gatsoulis and Andrew Reddington. What's also very clear was that if you replace the conduits, the second conduits did not quite last as the first conduits, which sets up a situation for multiple operations. So it was a very clear time, and I was exactly going to say what KK said, clear time for a need for a non-surgical intervention on the right ventricular outflow tract. Until then, all these surgical interventions were available, including stenting for bare metal stenting for stenotic conduits, but causing obligatory regurgitation. This was a timeline which shows how the Melody valve was developed, with the first implant in 2000, and the predecessor for that design was the introduction to Philip of the Contegra valve, and it was marketed as Venpro, which was as a surgical conduit. And it was the surgeon from Paris who actually gave it to Philip to say, look, this is a new conduit which has been given to me. Do you want to try it inside a stent? And that story actually doesn't get repeated often. This then remarkably changed to over 2 decades, nearly more than 10,000 implants all over the world. And it is quite interesting how the first design, which was frozen practically within 2 to 3 years of development, has still remained now as the iteration of Melody valve, which is used by everybody. But does it actually fulfill the needs? These are the different outflow tracts we see in young children and adults, with a wide variety of anatomical variations picked up from 3D imaging. How would a valve a size between 16 or 18 to 22 satisfy all these needs for patients who have both stenotic and regurgitation lesions, or indeed pure stenosis and regurgitation? Hence, there was development of various other valves. No wonder aortic valve implantation was a much larger population waiting for a valve, which moved from the pulmonary valve. And that same device came back for pulmonary valve implantation. And recently we had a 3-year outcome published by Ziad and Damien Kenny and the group. Essentially, all these valves which have been designed, I'll quickly run through the available valves, have shown the same results. The all-cause mortality and reinterventions are low. The gradient improves remarkably. The freedom from reinterventions is somewhere around 70-75% by the end of first decade in well-selected patients. Venous P valve, this is experience from many contributors in India, including Nageshwara and Shiva, from Thailand, Vorokan from Thailand, and Shak and Damien. Successful implantation in more than 95% of the cases, few valve migrations, and interestingly, stent fractures in patients who didn't have very tight calcified conduits. And this is related to repetitive stress injury from very dynamic compliant outflow tracts, 27%, which is way higher than what we saw in Melody, which was about 21%. The pulsar valve, which is quite a softer nitinol frame compared to the venous P, has a gentle dilatation at proximal and distal ends by about 4 millimeters. And this is from the Korean group who have a design for valve diameters between 18 and 28. Then the Altera adaptive stent as a pre-stent for larger outflow tracts based on Philip and Eugene Buchamlin's design of infundibulum reducer, as it used to be called. This is to allow for implantation of Sapien XT29 in very large outflow tracts. The stent acts as a holding device within which you can implant a valve. And of course, the Harmony transcatheter pulmonary valve, which is from Medtronic. It has asymmetric flanges distally and proximally, and it's a pericardial, porcine pericardial leaflet valve inside with diameters ranging up to 22 to 24 millimeters, which they have recently published their feasibility trial with good results for successful implantation and one case each for stent fracture and embolization for which the valve had to be removed and patients operated. So when we select patients, we are trying to relieve stenosis and achieve sustained relief. We are trying to achieve a size of the valve which gives the longest freedom from reintervention, particularly for pediatric patients. And for those with regurgitation, we try to abolish the regurgitation with safe anchoring to maintain stent integrity. In terms of the valves, you can have a list of valves, but the process of implanting them is also going through an innovation. Imaging is certainly an important part. This is an example of conventional imaging. On the left-hand panel, you see coronary testing with balloon interrogation, and the right-hand panel, you see a compliant balloon being used to assess the diameters, which can be done in orthogonal planes or multiple planes rather. So the advances in rotational angiography to create three-dimensional imaging showing spatial orientation of the bifurcation, relationship with coronary arteries, as well as sizing of the outflow tracts, a volume rendered image constructed. You could also actually try and use other advanced methods like 3D modeling using virtual reality. This is a model created from a patient who had a Glenn. It's not a pulmonary valve, but the same principle applies, where you see severe left pulmonary artery stenosis here. You see the Glenn circulation, SVC, RPA, and very severe LPA in a patient with hypoplast, where we model not just the heart, we also model the bronchus to know whether inflation of a stent within the left pulmonary artery will cause compression of the stent. So process innovation allows that, also allows for access to the right ventricular outflow tract by reducing the risk of trauma within the access sites. Injury to the IVC, injury to the tricuspid valve, patients with blocked veins trying to achieve direct access to PAs through subxiphoid approaches or thoracotomy approaches, which have been used for larger outflow tracts, and then modifications by allowing for anchoring with plication of the main pulmonary artery externally by surgery to allow fixation of the valve. What is more important for the interventional cardiologist with all the devices is to know what the outflow tracts are, what the sizes are. This is a valve-in-valve software which gives you true internal diameter for all bioprosthetic valves used by the surgeons. You need to know the risk of a calcified conduit, aortic or pulmonary homograft, not just in terms of compression to the coronary artery, in terms of when it would give way and inflate, but also dissection and rupture. And identify the non-dilatable conduits such as the Hancocks, where one would maybe get 1 or 2 or 4 years of freedom from the intervention, which is not worth the effort and the cost in these interventions. The valves have also been used in various gamut of other outflow tracts, which have been created by the surgeons. Importance of the conduit creation with pre-stenting in patients who have very difficult outflow tract morphologies, where you can create an implantation platform with stents to allow whatever valve is available for the interventional team. The indications are also expanded to increase the size of the implanted valve, trying to put it in small conduits which can be extended, or in prosthesis amenable for valve and valve implantations, and most interventional cardiologists are now quite familiar with this for pulmonary valve implantation. 2 decades down the road, the results which are seen are quite sustained, and this is the most recent, latest group of large. So we started off in UK, then the European team came up, and this is the latest results from Tom Jones from the US IDE results. They are still quite sustained with the freedom from reintervention to 17 from the operation to 79% and recatheterization to 72%. Not surprisingly, age-wise, the younger people, less than 20, children particularly, have a higher rate of reintervention. And endocarditis, which the incidence has been described anywhere between 4 and 8%. And there's a lot which is written on this about not just melody valve endocarditis, but endocarditis in patients who have melody valve implantation, and both are different. It is important to identify our patients where we would put these valves. Is it necessary to put a valve in a 14-year-old who has a 16 Hancock? I don't think so, because the Hancock is not distensible and you would not gain many months or years with that. We have to allow those patients to have the best valve suitable for them by surgery, which will have a longer period of freedom from reintervention. Again, elective implantation in patients who have severe pulmonary regurgitation, who are asymptomatic with preserved ejection fraction. Just because we can put a valve without surgery, we still have to question the wisdom of actually doing it too early. Similarly, is it important to use large valves and design them? I think it is more important to repair our congenital heart disease in such a way that when they grow up, the valves they need would not be larger than normal adult-sized valves, which are not more than 25 or 26 millimeters. The importance of preparation with imaging, the importance of reducing infective endocarditis risk, and the importance of choosing what residual lesion is acceptable for the arrhythmic burden, the burden of late death and RV dysfunction is very, very important when we think about pulmonary valve implantation. So first, we should do no harm. We should not put these valves in thinking that they are superior unless we design superior valves. We have to acknowledge the risk of infection. We have to acknowledge that when they need reintervention, it should be easy, either by the surgeon or by the cardiologist. For the future, it is very important to prepare for future interventions as much as not be in a situation of needing very large valves for normal-sized human beings. But all the other things for implantable devices would apply. Durable valves, small French, small profile, low profile transcatheter delivery systems, which are low with low traumatic burden, no anticoagulation, low infection risk, poor reactivity in terms of fibrosis and infectivity and potential growth. These are the future things to look out. I'm quite sure that within the next decade, there will be a resurgence of a push into inventions in pulmonary valve implantation. Thank you very much.
Thank you, Dr. Sachin. That was a wonderful presentation. And thanks for sharing your great experience with the Melody valve and giving a lot of insights about the other valves as well. And the need to have a good amount of caution in not to put in a valve in each and every patient and think about the alternative surgical options. Thank you very much.
Thank you very much, Sachin. Indeed, very good information, and data also showed very much encouraging. At this point of time, there are no questions, but since you have to leave, I think some work is there.
Yes.
We will post the questions to you.
No problem. No problem. Thank you very much. Bye-bye.
Thank you. Thank you. Saurabh and Shiva, can you please moderate and then do the subsequent session?
Nagesh sir, actually, I don't have the list of the presenters.
Okay.
So please, if you have, please.
Hi, good morning.
Good morning, Jay. We are able to see your slides.
Hi, Shiva.
Okay. Welcome, Dr. Jai Ranganath. Dr. Jai Ranganath is from Jaidava Institute of Cardiology, Bangalore. He is going to present a case on acquired aortic interruption transcatheter solutions.
Thank you, Dr. Nageshwara. Let me thank Dr. Srinivas Kumar for giving us the opportunity. This is acquired aortic interruption. So that means it's not in the real sense, the congenital aortic arch interruption, what we come across in neonates and infants. It's nothing but a coarctation of aorta, which go on to become progressively something like a chronic total occlusion. So I will present 2 or 3 cases here. This is a 30-year-old incidentally diagnosed to have a coarctation of aorta. It's a very classic coarctation pictures. This was done way back in 2016 in PCS as a part of the workshop. Myself, Dr. Nageshwara, Shak and Varakan, 4 of us had to do this case as a part of the workshop. Unfortunately, we don't get these kind of cases very often, because the numbers are very few, because most of the coarctations what we get will have a antegrade flow. That's not a major issue in dealing with nowadays. So this is the classical X-ray, which is showing a rib notching. This is a remarkable ECG. This is the CT. This CT is any kind of an intervention in a coarctation of aorta. CT is absolutely necessary nowadays because to plan the procedure. This is some of the measurements we need to do. The coarctation of aorta, proximal, distal, where is the origin of the subclavian arteries, carotid arteries, is there an aberrancy of any subclavian arteries? A lot of issues. So let me go directly into the case. We need to have, when you suspect the interruption of the aorta, there is a totally occluded aorta in a congenital coarctation of aorta. We know that from the echocardiogram does not show any antegrade flow. We have assured that it is 100% occlusion. So we have to have the upper limb of access. That's radial access, either the left or radial. It depends on your comfortability. Preferably, I think right or left is okay. So what are the issues we come across? Is crossing the lesion, because there is no antegrade flow. It is not very easy to cross these lesions. And jailing of the left subclavian artery, it is not a very major issue of late. Most important is crossing the lesion. So what are the strategies? You can use RF wire, which is not easily available in our settings. CTO wires, the coronary guide wires, stiff end of the thermo, hard wires, very rarely broken bone needle. Some people have used it, even we have done that in the past. So next is after crossing, next becomes easy. Just predilate with a small coronary balloons, then peripheral balloon, and don't completely predilate it, so that the stent will migrate if you completely make a complete passage there. So the strategy is here, put a stent, and you are jailing the subclavian here, you could see that, and then come back from the left side, left radial if you have the access, enter the aortic area, and then try to predilate. And nowadays, most of these stents have got a wide, the open stent design. It's not a major issue. Or otherwise, Dr. Shak, actually in this case, he thought of a very innovative stuff. They put a 2-wire, one in the subclavian and one in the ascending aorta. Without using the 2 balloons, they mount the stent, the covered stent on the 2 balloons, use a 14F sheath, the groin sheath, and then deploy. That's what our plan. So as you know that the crossing is not very easy. It took long time, more than 1.5 or 2 hours, used a lot of voice. Ultimately, we could get away with the standard chronic total excluded voice, the Shinobi voice, the miracle voice, so many voices are there. Once you get the access, then it becomes easy. Either you have to snare from the, if you have crossed from the below, it is invariably very difficult to cross from the below. That means the descending aorta. Make a way that I think I've skipped a lot of pictures here. We have pre-dilated it, we passed the wire, and we snared it from the top. So these are all some of the hardwares which are definitely necessary. Hardwires, the snares, the sheaths, the peripheral balloons. So now we have the two wires, both the subclavian and the ascending aorta, the two balloons, the peripheral balloons. I exactly don't remember the size of these balloons. I think 12 millimeter, 14 millimeter. I think Nageshwar Ram has been knowing that. I copied from this. I've taken this. So you see the mounting of the stent, the covered stent, the CP stent on the balloon. We use something called a preloading of this stent. Use the 14F sheath. Make sure beforehand that this stent, this covered stent, will go easily through the 14F sheath. The two balloons, you need to expand, balloon dilate simultaneously. So nicely it is flared. The distal end of the stent is nicely flared towards the, then use another two balloons and dilate it. It is nicely snugly sending into the coarctation of area and no compromise of the left subclavian. So this is the echo shows nice. This is one of the strategy which you could use, the double balloon technique. The importance here is the usefulness is displaying of the proximal end of the subclavian artery, expanding a partially exposed stent. So that's nice. That's a good strategy. This is another case which we have done. This is a standard coarctation of aorta, almost total occluded aorta. You could see that there's no antegrade flow on the echo, on the CT, and as well as the angiogram. Here we had a lot of difficulty once again. We need to have the two axes. The biplane cath lab will definitely come in handy here. We thought of using a broken throw needle, no success, but here we have to be very careful. We have to have the covered stent on the rack. It doesn't work many times. So one more try. What we did here was that we used the hard end of the Shinobi. We used the Mullin, the dilator to take the support, and in that we used the 1.4 wire and it crossed. Once it crosses, the rest becomes easy because you use a new balloons or the coronary balloons by 2 millimeter, 3 millimeter. Once you've done that, the rest of the procedure looks simple like any other coarctation of the aorta. So this is the 5014 stent. Ideally, we should use a covered stent, but we used because of issues. We had kept the stent on the rack. Nice result. This is follow-up. Here, both brachial, radial and femoral approach use different catheters. All these things are necessary. The case 3 is a boy, 14-year-old boy. And last year, once again, same thing. So used with a CTO wire, snared it becomes easy. This is, once again, it's not a covered stent, it's a regular stent, it's a formula stent. So let me acknowledge Dr. Shak, Varakan, Dr. Nageshwar Rao for sharing me this particular picture because I was also in the team of that procedure. Dr. Srinivas, my colleague at Jaydeva, for sharing me some of these pictures and helping me in doing some cases. So take home message is delineation of the anatomy in the CT angiogram. First of all, we should know that it is a totally occluded aorta, then only we can plan. So the accurate echocardiogram is extremely important. CT is definitely needed, it is mandatory. Hardware selection, you should have each and every hardware in your lab. Otherwise, you can't take the patient on the table and not finding out the hardware is not okay. The biplane cath lab will definitely help so that you can avoid a lot of time wastage and the contrast. Preferable to have the covered stents, definitely, no question about it. Should know when to give up because you tend to cause more problem if you keep on trying to cross the lesion with hardwares. You know that what could happen. They may not be successful in all the cases. That we should know our limitations in this particular interventions. Thank you very much.
Thank you very much, Dr. Jai Ranganath. It's a very great cases. Saurabh is there. Saurabh, can you please moderate the session?
Yeah, yes, please. Very good presentation and very great collection of cases by Dr. Jai Ranganath as always. I would like to add a few things. He mentioned very rightly that there is a great need of clarifying the imaging. For the benefit of those who are listening and all those who have not done it many times, CT is a modality which sometimes overestimate the length of total occlusion in the acquired atresia. So don't always go by the CT because sometimes the thicker sections don't give that correct impression. And it has happened with us in 1 or 2 cases where we thought that it is actually acquired atresia, and a coronary wire with O09 tip, which is like hydrophilic, slip through from femoral end, and then it becomes easy. So whenever you are analyzing a coarctation of aorta on CT, always ask for raw images which are thinner cuts. Don't believe on those 6 millimeter, 5 millimeter cuts because you are likely to miss those small thread of antegrade flow which is through that segment. And then if you can identify that, your job is much more easier than doing all that puncture and all. So that's what I wanted to add over here. Dr. Jayarangnath, any experience like that?
My understanding is that if any wire goes from the descending aorta, use any standard CTO wire or regular wire, flips to the hydrophilic wire into the descending aorta, I think there will be some lumen that Saurabh. It's almost always like that.
Yeah. So one good thing what I understood out of few cases which we did was that they are not aligned in the same fashion. They are in a different fashion. So the B plane, the LA or the lateral plane, if you are trying to go in the straight up line, your chances are much lesser. But if you are taking anterior course, the lower part, and then you take a slightly anterior course to enter to the upper part, there are higher chances of entering into the correct lumen.
Yeah. No, that's what the biplane lab does. I mean, definitely it's of a great use, but here most of our labs don't have a
I agree, sir. So
and also when you have a doubt, always go through the radial approach, and then if it is even it's a very small thin layer of hairline kind of antegrade flow, any hydrophilic wire will just walk through this occlusion, unless there is a clear cut occlusion.
With the interest of time, I think we request Dr. Shweta to share her screen. And Dr. Shweta is a pediatric cardiologist at Rainbow Children Heart Institute, Hyderabad. She is going to present a case on transcatheter solutions, interventions of umbilical arteriovenous malformation.
So, good evening, everyone. I thank Dr. Srinivas Kumar for having all of us here. I think I'm audible.
Yes, you are audible.
Yes. So I'm going to present a case of a newborn who presented like a PPHN to us. And so just give me a moment so that I can go to the PPT mode. Yes. So this is a 9 days old newborn who came to us with the history of tachypnea and respiratory distress, and saturations were normal. There were bounding pulses and 3/6 ejection systolic murmur. And we can see at the X-ray that there is a cardiomegaly. So actually this baby was discharged from the gynec unit saying that everything is fine and can go home. But after 3 days of life, again started having tachypnea, which is noticed by the family. And then eventually they came back to the neonatology unit saying that the outside echo is suggestive of PPHN and needs admission. So he was transferred from another unit and the primary diagnosis was PPHN. And on our workup, there was significant renal failure to this patient as seen by the kidney function test reports, like urea was 69, creat was 2.2, and septic workup was negative. And what ultrasound abdomen showed that there is a dilatation of the ductus venosus and portal vein. So with that course, they called us because there was a baseline diagnosis of persistent pulmonary artery hypertension. So eventually, the baby developed multiple right focal seizures, and because of that, the MRI was done, which showed that there is a diffuse cerebral edema, and baby was going into one by one different organ involvement. Initially started with heart, then kidneys, and then brain. So this was the initial echocardiogram, surface echocardiogram, which showed that there is a right heart dilatation and severe tricuspid regurgitation with severe pulmonary artery hypertension, with right heart, with right ventricle, which is dysfunctional. And as we can see on the right side panel, that portal vein indeed looked dilated. The ductus venosus was present at around day 9 of life, and we can still see the flow which was coming into the umbilical vein, which is a bit unusual at this age. So we can see that my arrow is pointing towards the umbilical vein. That's the usually dilated portal sinus, and then there is a persistence of ductus venosus. Sometimes we can see this persistent even till day 15 of life, especially in pulmonary hypertension cases. So with that, because there was a still flow seen into the umbilical vein, that gave me a suspicion that once the cord clamping happens, we should not see a flow which is coming from the umbilical vein. So that means something abnormal is happening. So immediately I looked at the umbilical cord, and it looked such a huge, bulky, and there was a thrill which was present at the base of the cord. And I'll play the thrill part if you all of can listen it. So this was at the base of the cord. This thrill could be heard and could be felt. So with same clinical clue, the descending aorta was traced, and it was hyperpulsatile, and where the thrill was felt when the probe was kept at that area, we felt that there is a abnormal communication between the one of the artery into the vein, which was suggestive of this continuous Doppler. So this made us the clue of the umbilical AV malformation from the background that there was a flow which was coming into the umbilical vein. There was a umbilical cord which was pulsatile, and a thrill was felt at the bottom of that. And because of AV malformation, the child had high cardiac output state, which led to the pulmonary hypertension as well. Yes. So to explain our adult cardiologist, I'm sure all of you are familiar with fetoplacental circulation, that there are normally two umbilical arteries which end into the placenta and carry so-called deoxygenated blood. And there is an umbilical vein which is single, carries the oxygenated blood from the placenta, and it bypasses the liver through the ductus venosus and enters into the heart. So usually there is no communication between the umbilical artery and the vein, and it actually forms the capillary bed called as fetal umbilical circulation into the placenta, and that's why there is no direct communication between the artery and the vein. But in this situation, there was a communication which was happening at the cord level. Probably it existed extra cardiac and also it existed extra abdominal and within the umbilical cord as well, which led to the high cardiac output state. So CT scan confirmed the findings that there were feeding vessels from the both right and left umbilical arteries, but right umbilical artery was the major source of supply, and left umbilical artery was also dilated, but it was not giving as much as feeder as right umbilical artery. And because this child was symptomatic and with PPHN involving multiple organs like renal failure and had cerebral edema as well, with high cardiac output failure, we have to take decision to close this AV malformation. So it was decided to close by the transcatheter method, and the child was taken to the cath lab. So this complication of this particular entity I want to highlight here, because once the cord gets dried off, there is a natural tendency of it to fall. But it does not cause any significant bleeding because of the anastomosis gets closed off and it gets thrombosed. But in this situation, there was a continuous communication between the artery and vein. So as soon as this cord fall off into the cath lab, it caused catastrophic blood spur, which was coming out from the umbilicus. So actually, we thought that we may lose this child within the minutes. It was that massive spur was happening. So immediately after compression and blood transfusion, some purse string sutures were taken. And since we already had a right axillary access, which we thought that will be better to access this particular channel, we have taken this initially a glide catheter and profiled that the communication was still existing. It was not closed despite of those sutures. So first we closed that as per our thought process that it should be sufficed, the closure should be completed by 8 mm AVP4, which can easily go through the even diagnostic catheter. But after deploying AVP4, there was still a leak and some oozing was happening from that side. So we didn't wanted to leave this residual communication as it is, and that's why we kept some more coils there. But after deploying coils also, the communication was still persistent and the oozing was still there. So to the fear of that it can bleed further and the feeders can increase in size, we finally decided that we need to close the proximal part of the communication also, proximal part of the right umbilical artery. So we decided to go through with the 7.5 multifunctional occluder. Because it has advantage to go through a guide catheter 5 French, which was already there in position, it did not take much of the time. And after deploying the device, the channel was completely closed, as we can see here. So post procedure, this then very next day the baby could be extubated and the right heart was normalized and PA pressure. There was only mild pulmonary artery hypertension. So over a couple of days we could discharge the baby. So I would like to highlight the possible complications of umbilical AVM. So during fetal life also it can present like fetal hydrops, cardiomegaly, or can have fetal demise. And it can have acute hemorrhage due to the fall of the cord, or it can present like PPHN and high cardiac output failure like it has happened in our child. And it can sometimes lead to liver derangement as well, pre and post procedure. So there are a lot of literature about umbilical AV malformation, but they all were tackled to the surgical methods. But here, because of the easy access, and we thought that there is a possibility that we can close it through the transcatheter method, we went ahead with the right axillary approach and did the job. So I would like to conclude my session by saying that the PPHN is a diagnosis of exclusion. Try to search for all the possible causes. If you don't find in one setting, please go ahead and look at the clinical signs. They give a lot of clues. And transcatheter closure is possible, but be aware of the complication of hemorrhage. It can be really disastrous. So thank you all.
Thank you very much, Dr. Shweta. That was a wonderful presentation. I just wanted to know what is the time of occurrence of this umbilical arteriovenous communication? Was it perinatal when they put the clamp and it was a traumatic AV fistula?
Intrauterine also it is described. So I won't say that it is iatrogenic. And obviously it was present intra-abdominal as well. You can see the CT scan. So CT scan suggested that it is intra-abdominal as well. Otherwise, our purse string suture would have just closed the AV fistula. So I would say that it is a congenital AV malformation and may not be the acquired one after the clamping.
That bulging part was the one that fell off.
The some nidus, yes, this some part, the cord where it was pulsatile fell off as soon as it dried, and some part intra-abdominal was still persistent. So I think it's
given the fact that the child had a relatively uneven full prenatal period and the delivery and the gynecologist was cool enough to discharge the baby, I was just thinking in my mind whether this particular event is just a crushing of the artery and the vein and creating a traumatic arteriovenous fistula, and then the veins can remodel, arteries can remodel, they can become larger and larger because you have a communication. I was just thinking about it. The two references that you showed, one was a newborn and one was an 18
Yes,
month
one
baby.
was 18 month. Yes. I actually wanted to quote that the one was 18 month asymptomatic and incidental. They actually found that it's an umbilical hernia, but during clinical examination, they felt there is a thrill there and it was pulsatile. Then retrospectively, they did CT scan and found out there is actually AVM. So I think it's congenital, but somehow it was not picked up during fetal life.
So very good case, Dr. Shweta. Quite a bit of learning for all the pediatricians who might be seeing such cases. And sometimes we wonder why a child is having bleeding from like some of those cases may be like this. And
yes.
We tend to think we don't know why actually the patient died. And I think occasionally we have heard some stories like that, but possibly this was the case in those cases. So
Yes.
thank you very much for sharing the case and showing it so elegantly with all the supporting images. So thank you so much. We'll go to the next presentation by Dr. Kavita. She's from Apollo, Hyderabad. Dr. Kavita, are you there?
Yeah, good evening, Dr. Saurabh.
Yeah, good evening.
Can you hear me?
Yeah, you
If
please go
Shweta
ahead.
can,
Yeah,
yeah,
unmute
Shweta
myself.
can still
Yeah.
on.
Shweta, can you switch off your share screen?
Yes, yes.
Yeah, then only she'll, Dr. Kavita will be able to share her screen. Yeah, okay, Dr. Kavita, please.
Nice case, Shweta.
Thank you.
Okay, just wanted to share this. I was hoping there'll be more adult cardiologists for this pediatric structural session. So I'm going to share with you a 16-year-old boy who was born with complex functional single ventricle disease that consisted of a complete AV septal defect, double outlet right ventricle, and unroutable aorta with severe pulmonary hypoplasia. So a complex anatomy he had, and he underwent, as an initial procedure, he presented at the age of 12 years and cyanotic, and we did a bilateral bidirectional Glenn because he had bilateral SVCs, and he underwent PA interruption. The following year, about 1.5 years later, he underwent the extracardiac Fontan operation, where we used a 20 millimeter PTFE conduit and created a 4 millimeter penetration. If there are any adult cardiologists, I just wanted to show this diagram where it's an extracardiac conduit from the IVC to the RPA, which diverts all the systemic venous blood, separating it from the arterial blood. And he had a pulmonary artery ligated at the first operation, and then he had some LPA stenosis that was also taken care of surgically. So he did well for about 1.5 years after the surgery, and about middle of 2018 and 19, he at follow-up in the outpatient, we noticed that he has complaints of intermittent body edema, and on evaluation, he had hypoalbuminemia with a range of about 1 to 1.5. And we made a diagnosis of protein-losing enteropathy for him, and he had persistent hypoalbuminemia. We treated with medications. He was in control, but always low in albumin. Then in mid-2019, he presented with facial puffiness that was increased, abdominal distension that was kind of new, pedal edema, and he also complained of right ankle pain that was there for the last 10 days. On physical exam, he was 44 kilos. The vitals were all normal. He was not tachypneic or in respiratory distress. He didn't look particularly cyanotic. Auscultation of lungs revealed that there was decreased breath sounds in his right base. Abdomen revealed moderate hepatomegaly. There was mild splenomegaly, and there was an abdominal fluid thrill. When we examined his right leg, the right ankle was warm to touch. There was swelling, tenderness with erythema, and he also had bilateral pedal edema. He had mild facial edema with a normal S1 and a single S2, and his peripheral vascular exam was fine. So this was the initial X-ray in the outpatient department. So shows a significant or moderate degree of pleural effusion with obliteration of costophrenic angle and the Ellis S sign. Then his echocardiogram in the outpatient department shows a mildly hypoplastic right ventricle, normally contracted left ventricle,
it's okay.
common AV valve, and with mild AV valve regurgitation. So this is his extracardiac Fontan conduit, and we were trying to see if the fenestration was patent. As you can see, it was a little difficult to see any right to left shunt. Maybe this was a little bit of shunting, but it was difficult.
So it's okay if we cancel it also.
Dr. Shiv Kumar. Okay. So on his lab work, his hemoglobin was 15.4. There was nothing remarkable. There were no signs of infection. And for his ankle, we did ASO titer rheumatic factor and also had a rheumatology consultation. Of the labs, the remarkable was a total protein that was low at 2.6, and his albumin was only 0.8 at that time. Ultrasound abdomen showed the same moderate right pleural effusion with underlying collapse and consolidation, and there was hepatomegaly with mild ascites. So he was managed medically during the initial few days. We placed a right ICD, and there was continuous pleural drainage, which was, remarkable. He was making about, anywhere between 300 to 1200 ml per day. It was non-chylous, both by exam and by lab data, and it was transudative in nature. Then his ankle was diagnosed as a reactive arthritis secondary to his systemic illness and pleural effusion, and it was symptomatically treated, with which it improved. Then for his protein-losing enteropathy, he was already on diuretics, ACE inhibitors, and pulmonary vasodilators, also high-protein diet. Then we added steroids, warfarin, octreotide infusions, albumin infusions he was receiving. So we tried this medical therapy for about a week to 10 days, but the pleural effusion continued to drain. So we took him to the cardiac cath lab, particularly to evaluate his hemodynamics, to relieve any obstructive lesions, to close any collaterals, and also to see if his fenestration was patent. So this is more for the adult cardiologist. So the fenestration of Fontan pathway, if you look at the literature, mostly done in the early postoperative period to improve cardiac output. It also decreases the duration of pleural effusions and the length of the stay that is associated with post-op Fontan physiology. It is also known to decrease morbidity and mortality, and physiologically decreases the venous pressure and also decreases lymphatic problems such as chylothorax. So most of the procedures described have been in the immediate post-op period, and also sometimes late Fontan complications like failing Fontan circulation, protein-losing enteropathy, and plastic bronchitis have been treated with fenestrating the Fontans. Few cases, and then it could be static balloon dilatation, where the results have been variable depending on the procedure, the closure rate, or the rate of closure following balloon dilatation has been poor. Then stenting and fenestration, I was looking at data from India, and really there aren't any reports that, although we know, people have been doing, from the conferences, but there's no data that is published from India about the stenting fenestration. I know Dr. Shivkumar has recently published the atrial flow regulator for regulating the fenestration size in Fontan patients. So in the cath lab's hemodynamic data, his Fontan conduit pressures were not too bad. The mean was about 10, and there was no gradient from the pulmonary artery to the Fontan conduit. The EDP was 5, giving a transpulmonary gradient that was decent at 5, and his cardiac output was 3.2, and the pulmonary vascular resistance was also within normal limits. So this angiogram shows a pigtail catheter in the extracardiac conduit showing good flow, no areas of stenosis. And we're trying to see if there's any, maybe there's a tiny shunt or actually no right to left shunt across the fenestration. And here we are with a JR catheter. I was looking at the right Glen anastomosis, which was patent. A tiny venous collateral is seen in the esophagus area. This shows the left SVC flow good to the left pulmonary artery. So there's no stenosis in those areas. Both the lungs filled adequately. And we were looking basically for all causes that can cause pleural effusion, such as aortopulmonary collaterals or other venous collaterals. And all these selective REMA, LEMA, and aortograms did not show any major lung filling. Then I tried to cross the fenestration initially it crossed with the help of a 5JR and a Termo catheter, but immediately as I was trying to advance the catheter, the wire came back into the Fontan conduit, and after that for almost half an hour with different combinations of 4JR5 and different catheters and wires, I was not able to cross the tiny fenestration after that subsequently. So I decided to make a fenestration in the area where you see there's a little bump here, so that was the area of the fenestration. So I tried to exchange it with 7 French St. Jude's sheath, and this is a lateral view of the same Fontan conduit. And so I tried to use a BLK needle, septostomy needle, to create a bigger fenestration, but the PTFE membrane was tough and rigid, and every time it was stenting, but I was not able to make a hole through it. So we tried for some time. And then we were not actually, the transeptal needle didn't give in, but I think again with different hardwares we tried, and again one more time the wire went into the fenestration. And then we static dilated it using a coronary 2 mm balloon initially, followed by a 5 mm balloon. And then after dilation, we mounted a 6 by 12 Herculing stent over, which is a pre-mounted balloon over a balloon, and then we dilated it, and subsequently deployed the stent. The stent position seems good, with 50% in the conduit and 50% lateral mass. There was a good right to left shunt at this point without any extravasation in the space. So this was a good result at the end of it. So the procedure was quite long with difficulty accessing the left atrium. So this shows the final result where the shunting was good across the stent. Now, post-procedure hemodynamics, the Fontan conduit pressure was not significantly different. The mean from 10 changed to 9, and the saturations also from a 98%. Saturations were decent at 96%. Now, post-procedure course, the pleural drainage over the next 7 days gradually decreased, and we were able to remove the ICD in 10 days. And the albumin from 0.8 went to 1.6, so doubled in 1 week after stenting, and it was 3.5 normal level after 3 weeks. So this was a little dramatic. I mean, I've done cases before fenestrating the Fontan for PLE, but the results were not as dramatic. So this kid is doing very well. At the recent follow-up at 9 months, he's doing well. He's maintaining 3.5 milligram per DL, and is basically, I was able to take down most of the medications that we were doing for the PLE. So this is a good result with that procedure. So in summary, this is a 16-year-old suffering from post-Fontan dreaded complications, which is PLE, and the pleural effusion could be related to PLE or independent of that, which is refractory to medical therapy and is treated successfully fenestrating and stenting the extracardiac Fontan conduit by a procedure that was quite technically challenging on this particular patient. So I think the result is dramatic. So we should consider this, all Fontan patients who are presenting with late complications such as this. Thank you.
Thank you, Dr. Kavita. Thank you, Dr. Nageshwar and Dr. Shivkumar. Thanks for agreeing to keep the session on time. And we had a very interesting discussions about the newer innovations and pulmonary valve implantation by Dr. Sachin. And then we had a Konar MF device talk by Dr. Nageshwar and had interesting cases of acquired aortic interruption and umbilical AVM, now post-Fontan fenestration. Thank you all. Thanks, Nageshwar, for helping us in doing this. And thanks, Shiva, for agreeing for this. And I think we have going to another newer interesting session, which all logins who have logged 1,500 doctors are waiting eagerly. Thank you, Dr. I see Dr. Martin Leon now, sir. Thanks for sparing your valuable time for us, sir. And we are extremely thankful to you for all your encouragement and all your support throughout. I've been very happy to inform that this ETCT meeting came out quite well, sir. Large number of attendees both yesterday and today. We had about 1890 yesterday and about 800 today, and we are eagerly waiting to hear all of you. And thanks for extremely always being cooperative and adjusting your schedule. He was supposed to have some other thing, but we requested him to be part of it. Thanks for agreeing it, sir. And I now request Dr. Sushil and Dr. Eberhard Grube to chair the session along with Dr. Martin Leon and conduct the proceedings. Over to you, Dr. Sushil.
Wonderful. Srinivas, can you hear me okay?
Yeah, we are able to hear you.
Perfect. So just I want to thank all of the attendees and participants. It's wonderful to be a part of TCT India South Asia this year. Unfortunately, we can't be there in person, but I think you've created this micro environment and microsite to help make it as easy as possible for people to get the learning that they want. And it's my pleasure to co-host this with a friend and colleague, Eberhard, for this session. And to start off, we're going to talk. I know transcatheter valve continues to grow in India, but we want to sort of share some of the knowledge over the last 10 plus years that we've gained in our experience and what to do, what not to do, and sort of how the evolution has occurred. And sort of to give an overview and lead it off, my mentor and colleague, Marty Leon, is going to start with TAVR and low-risk patients and sort of talk about what we're missing right now and what we need to still get and what we've learned. Thank you, Marty, for joining.
Sushil, thank you very much. Can you hear me okay?
Yes, absolutely.
Excellent. Srinivas, it's really a pleasure. I've had an opportunity to be at TCT India many times. The hospitality, the quality of the educational experience, the engagement of the audience has always been terrific. So each of my trips to Hyderabad have been extraordinary and memorable. I wish I could be there with you. Unfortunately, circumstances are otherwise, but you've created a striking environment in terms of being able to do an online course. So I congratulate you on the innovation that you brought to this as well. I'm going to try to make a contribution to this master class, which is hosted by Sushil and Eberhard, two of my closest friends. And I'm going to emphasize something that's becoming more and more of an issue, certainly in the United States and Europe as well, as we continue to accumulate data and expand the indications of TAVR to more and more patient groups. So I'll give a brief overview, but really as a lead up to the topic of TAVR in low-risk patients. These are my disclosures. So beginning with some background, I often begin these lectures by paying tribute to one of my close friends and colleagues, Alain Cribier, who's well known to India and truly was the first-in-man pioneer, having done the initial proof of concept case in a desperately ill man with bicuspid aortic valve disease more than 18 years ago. This procedure was done with an antegrade approach, without general anesthesia, without transesophageal echo, and this is the patient who was in cardiogenic shock 15 minutes later. So this told us at that time that this procedure could be done. But immediately in a conversation I had with Alain, we began discussing what would occur next. And we began to speculate as to what the vision of this procedure could be. Many people think that the TAVR resolution was a random event. I would argue that it was not, that it was the inevitable result of decades of very bold progressive iteration in surgery, in cardiac imaging, and in transcatheter therapies. But even those of us who were most positive about the potential of this new therapy almost 2 decades ago could never have predicted that we'd see such a rapid evolution of technology, that we'd see so many procedural refinements and simplification, making this generalizable to practicing physicians. What I can describe as an avalanche of clinical evidence supporting its use in various circumstances, the adoption or acceptance of what we call the heart valve team, and then finally a dramatic reduction in complications with improved outcomes. All of this has resulted, as an example, this is just looking at isolated aortic valve replacement over the course of 4 years, and you can see the striking changes in the United States, where by the end of 2018, more than 2-fold greater TAVRs were being done than surgery in isolated AVR procedures, something that was truly unexpected. The prediction is that in 2020, there may be as many as 100,000 TAVRs done in the United States alone. Now, as you're aware, the technology really is supported by 2 basic genres of devices, the self-expanding and the balloon expandable devices. But embedded within this, there's been dramatic evolution and iteration over the years. And these changes have all been very meaningful, reducing the profile, virtually eliminating paravalvular leak, many different changes in the design of the device and the delivery system, making this an easier procedure to do, particularly using the transfemoral access approach. This slide shows 24 randomized trials in TAVR that are either completed or ongoing. Put this in perspective. Surgery has been around for 60 years. Before TAVR, there were no randomized trials in surgery. So I can tell you that this explosion of clinical evidence has made a great difference. In the United States alone, more than 15,000 patients in 10 randomized trials with multiple generations of 4 different TAVR systems. When we just look at the balloon expandable partner experience over the course of a little more than a decade, we enrolled more than 9,000 patients in 5 randomized trials, and we published 200 manuscripts and abstracts from these data. I do believe that it's critical to have clinical evidence to be able to demonstrate that this therapy is meaningful And when somebody shows me a new TAVR system with a few handfuls of patients and promotes this as being the next greatest device, I think we need to put that in perspective given what's happened over the past decade. This concept of the heart team has evolved also. There are many people who participate. Certainly our surgical colleagues, our imaging experts, heart failure specialists, a variety of other non-physician specialists. But I tell you also more and more, the patient and the referring doctor are now at the center of the heart team, and particularly in low-risk patients. The concept that we'll introduce of shared decision-making becomes a meaningful component of deciding which patients should be candidates. When we look at the partner trials over the course of a decade and just look at 30-day mortality, there has been more than a 15-fold reduction in 30-day mortality from the first study that we did to the most recent trials. And this is one of the reasons why this technique has become so generalized in places like the United States and Europe. So let's now focus on the low-risk trials. As I've mentioned, within the partner trials, we studied extreme risk, high risk, intermediate risk, but we really didn't know if we could be competitive with high-quality surgery in the lowest risk, younger patients. This aggregate of evidence has resulted in important guidelines, and these guidelines have clearly indicated that TAVR is either preferred or non-inferior to surgery, a good alternative in all of these other risk categories based upon using surgical risk scores and other ways to categorize these patients. It's early in the morning here in the United States, so if you like a mocha cappuccino, you can put in perspective the contribution of these non-low-risk studies. By the STS database in over 140,000 patients, you can see that only 20% of the overall patients who get aortic valve replacement fall in non-low-risk categories. But truly, the holy grail is the 80% of patients who are in the low-risk category, which we literally have not studied in any systematic way. Now, it's not early in the morning, it's later in the day, certainly in India, so maybe instead of a mocha cappuccino, you'll be drinking an IPA shortly, but this is really what we're talking about. So to get to the core of the majority of AS patients, you need to address the issue of low-risk aortic stenosis. I think this area was forever changed in 2019 in the spring at the ACC, when two randomized clinical trials were presented and published simultaneously in the New England Journal of Medicine, representing the balloon expandable and the self-expanding technologies in low-risk patients. This is the first of those studies, the Partner 3 trial, and these were, again, low-risk patients, severe AS, randomly allocated, 1,000 patients, to either TAVR using a transfemoral approach or surgery with a follow-up that will extend to 10 years with a primary endpoint at 1 year of a composite including mortality, stroke, and rehospitalization. These are truly low-risk patients. They are very different from the standpoint of demographics. The mean age now is 73. There's a male predominance. The STS scores are less than 2. Only less than a third of the patients had severe symptoms and very few comorbidities. Only 15% had atrial fibrillation, less than 3% had previous permanent pacemakers, and there was no frailty. This is a very different patient population when we start studying the low-risk individuals. The primary endpoint, as I mentioned, was a triple composite endpoint in this study, and it was powered for non-inferiority, which it clearly was, as there was a 46% reduction in death, stroke, or rehospitalization with TAVR compared with surgery, which also met superiority criteria as well. If we just look at all stroke, there was a significant reduction in all stroke. Many people think that TAVR has a higher stroke rate than surgery. That's not correct. It's certainly not correct in the low-risk patients. This is an important endpoint, death or disabling stroke. At a year, there was about a 3-fold difference, favoring TAVR in death or disabling stroke. So when we look at that particular trial, there were some endpoints where surgery was better, mild PVR, new left bundle branch block. There were many where the two were relatively similar, including the need for new pacemakers, as an example, but there were also many in which TAVR appeared to be better, including mortality, strokes, rehospitalization, and many other secondary endpoints, especially those allowing the patient to recover more quickly and leave the hospital soon. So you'll have to decide which therapy do you think is better for your patients. In fact, if you look at a typical patient, the clinical care pathway is that the patients are admitted the same day. 3/4 of the patients do not have general anesthesia, so it's done sedated awake. It's a femoral artery puncture, less than 1 hour procedure. Average time is 58 minutes. 3/4 of the patients did not go to an ICU, and they were discharged in 1 to 2 days. 96% of the patients were discharged to home or self-care. And the clinical outcomes were striking. Very few procedural complications. At 30 days, a mortality of well under 1%, and there were no serious strokes. Less pain, bleeding, acute kidney injury, or arrhythmias, and improved early recovery, and I cannot emphasize this enough, and with a 1-year mortality of only 1% and a serious stroke rate of 0.2%. These were the results in a randomized clinical trial in low-risk patients. So this allowed us to complete the cycle and to show these results in the New England Journal of Medicine, which for us was very fulfilling. But I also believe that this was important because the effect was amplified by showing a similar study in similar patients with a different self-expanding device versus surgery, a randomized trial with almost identical outcomes. And this is the Evolute low-risk trial, the study design shown here. The methodologies were slightly different. The primary endpoint was death and disabling stroke. This was a Bayesian adaptive design with an interim analysis. So a little bit different. Sample size was similar. It was a 2-year primary analysis outcome. But the primary endpoint met the TAVR non-inferiority criteria as shown here. And if you look at the Kaplan-Meier curves out to a year, you again see the TAVR was superior to surgery, at least numerically in this clinical trial, out to a year. And if you look at the stacked bar diagram of the major endpoints, death favoring TAVR, disabling stroke, very much favoring TAVR, heart failure hospitalizations, again, and if you look at these three together, a statistically significant difference favoring TAVR at 1 year. And in this study, hemodynamically, the valve was superior at all time points to surgery, looking at serial echocardiogram. So these are striking and consistent outcomes. So much so that Eugene Brownwald, at the end of these presentations, said that this was a historic moment and all of us should remember it as such, feeling that things had suddenly changed. So let's put this in perspective and let's synthesize the results and think about where we're going from here. Soon after these trials, there was a meta-analysis that was published in the European Heart Journal, looking at 7 of the randomized trials between surgery and TAVR. It was a well-done study. Looking at mortality, and this is now over 8,000 patients, at the various risk categories, there's consistency and a 17% relative risk reduction up to 2 years, favoring TAVR versus surgery. This was independent of the risk category, high risk, intermediate risk, and low risk. There was a difference depending upon the access route. If you couldn't do transfemoral, the results were not as good. So these good results we're talking about are largely confined to the transfemoral access cohort. There was no important difference between balloon expandable or self-expanding devices. They were similarly effective in reducing mortality. These are the results with stroke, a 19% relative risk reduction. Remember, these are 8,000 randomized patients. And these are other secondary endpoints: acute kidney injury, new onset atrial fibrillation, major bleeding, again showing significant reductions, averaging around 50% of TAVR versus surgery. And these secondary endpoints are non-trivial to many patients. So this is one of Sushil's slides that he put together many years ago. And I do believe that the treatment paradigm has shifted. In the beginning, for the first decade, as we were doing TAVR, we would say that we could do TAVR in those patients where surgery would be higher risk. in patients who would do poorly with surgery. That was the sweet spot for TAVR. I think now things have changed and it's completely turned around. And it's turned in the sense that if you have good anatomy and good clinical indications for TAVR, it should be considered as the primary procedure. And surgery should only be considered in those patients who are not good candidates for TAVR. So what are the indications as we look at this low-risk category? The first caveat, many patients, we estimate about 30%, were excluded from these randomized trials for various reasons. So you can't say it applies to all low-risk patients. Very important for you to consider. I mentioned the two randomized trials, Partner 3 and Evolute Low Risk, but actually there are four. There's the earlier Notion trial, which is a smaller study from Denmark, and there's the more recent UK TAVI study, which also, for the most part, was low risk. So this is now 3,661 low-risk patients, and we've just completed a meta-analysis in all of these patients, which is not published yet. But there were many patients who were excluded from the low-risk trials, and you must be aware of that. So we didn't look carefully at low-flow severe AS, or bicuspid morphology, or multi-valve disease, or patients with concomitant coronary, kidney, or reduced ejection fraction disease. There are some patients with high-risk TAVR anatomy with severe calcification extending into the LV outflow tract, or other high-risk surgical patients that were similarly excluded. So you must take this into consideration. When I think about how we advise low-risk patients, we use 5 golden rules. The first is we no longer really look to surgical risk profiles as being the important thing to consider about choosing surgery versus TAVR. Second, transfemoral access is fundamental. It is clearly preferred. In a low-risk patient, if it's not transfemoral access, arterial access, you have to think about whether or not surgery is better. Age in low-risk patients becomes a very important determinant. And as we'll talk, if you're under the age of 65, we would only recommend TAVR if there are special considerations, such as significant comorbidities. If the TAVR anatomy is unfavorable, surgery should be preferred in low-risk patients. And you need, in this particular group, to pay careful attention to patient preferences, and you need to go through what we call this shared decision-making process to describe the risks and benefits of both and enlist the patient and their family in making the decision as to what is the better therapy. What about technology and procedural considerations? I believe that for most low-risk patients, maybe about 80%, TAVR can be performed with similar outcomes using either balloon expandable or self-expanding systems. There may be 20% of patients where we would prefer to use one or the other. Somewhat controversial, we could discuss that offline. Generally, we would only use carefully studied TAVR systems with randomized trial validation in low-risk patients. I don't believe that each one of these devices are equivalent and that this is a genre. I believe you need to be careful about generalizing the results of randomized trials to every device. There are many new and interesting and useful accessory devices for TAVR which you should be aware of. This is a list of them. I'm not going to go through all of them for sure. Embolic protection, pre-shaped guide wires, large hole closure devices, many things now that have made the procedure easier. And these are just two examples, the Sentinel cerebral protection device and the Manta large hole closure device. This procedural simplification, or the minimalist approach, has really transformed TAVR into a more routine and generalizable procedure. But you still need to be facile with general anesthesia, transesophageal echo, and alternative access in select patients if you want to predictably get very good results in all of your cases. This minimalist strategy involves many different things, and we don't have time to go through this, but the idea of so-called conscious sedation, not requiring transesophageal echo, fewer IV lines, not using ICUs to recover patients, and rapid ambulation and discharge are all components. We would say almost everyone is a candidate for some version of a minimalist strategy, and at least at Columbia, our median length of stays after TAVR is only 1 to 2 days. This is an example. This is Philippe General, one of our former fellows, one of our proteges, who did one of the first outpatient same-day TAVRs, where a patient came in that morning and was discharged at 5 p.m. that day after a successful procedure. And during the height of the pandemic, when we were only doing urgent cases, we actually did some same-day discharges, and it is feasible. I wouldn't recommend it in most patients, but it gives you an idea as to how far you can go with this minimalist strategy. And finally, there are many knowledge gaps. There are still things we need to learn. I'm certainly, we're humble in realizing that there's a lot of information that we need to integrate in the future. We don't know if the embolic protection devices that we often use, that we think reduce strokes, should be used systematically in everyone or selectively. There's a whole issue of valve leaflet thickening that has emerged, that has been observed mainly on CT studies, and this issue of clinical valve thrombosis. There's no question that bioprosthetic valve durability, we have many new definitions now, will become important in the future as we look to not just 5, but now 10-year and longer results. The safety and durability of a TAV and TAV procedure, if you have bioprosthetic failure in a TAVI device. We're just beginning to understand this. The safety of failed TAVR surgical explantation, if you have a failed TAVR, and what the implications are. Issues relating to coronary access, management of some of the conduction disturbances, including both the need for new pacemakers and new left bundle branch block. We're designing many randomized trials to look at the optimal antithrombotic pharmacotherapy. This is a new field. The management of AS with other concomitant diseases like severe coronary disease, chronic kidney disease, multi-valve disease. And finally, and very importantly, in younger patients with aortic stenosis who are low risk, it's the life journey that becomes important. You can predict they're going to have multiple procedures, and you have to make choices about which one comes first. So just to be provocative, in the younger, low-risk AS patient, age matters. In the very young patients who are less than 50, many of these are going to be bicuspids. Surgery is going to be preferred. And in many of these, a mechanical valve. In the 50 to 65-year-old patients, surgery would probably still be preferred. And then I think there's controversy about mechanical versus bioprosthetic. We would only consider TAVR if there were adverse circumstances with doing surgery. But the real group that becomes interesting to me is the 65 to 75-year-old group, and that happens to be my age. I have an STS score of 0.8. Would you do surgery or TAVR? Perhaps if TAVR was ideal, it could be first, or there were some adverse reasons for doing surgery. Here's where the shared decision-making and the discussion with the patient becomes very important. I would argue over the age of 75, TAVR should be preferred, not just an alternative, unless there are adverse reasons not to do TAVR that I consider doing surgery in these older patients. So in this younger group, which should you do first? Should you do TAVR? This is an example. If you do TAVR first and you have a second procedure, would you do a TAV and TAV? And then if that fails later on in life, would you do late surgery? Making these decisions is difficult. I think they need to be made in the moment and based upon a variety of clear thinking, anatomic factors, and clinical data. As an alternative, you could start with surgery in that 65 to 75-year-old patient. And then after the first failure of the bioprosthetic valve, which inevitably will occur, you can do a TAV and SAV. That's something we commonly do. But if that fails, you're looking at a second operation, and that's 2 surgeries, which is something that I prefer to avoid. But these are the alternatives that we have to consider. So many things unresolved, and this is becoming an exciting area as we begin to emerge into offering routinely TAVR as an alternative in somewhat younger patients who are in these low-risk categories. So this is my last slide, and it brings me back to Alain Crevier, because Alain really was the pioneer who had the persistence, the courage, and the vision to initiate this therapy. And I know he's been, as I said, has been a friend to India, has been to India many, many times, has introduced many new technologies in treating rheumatic valvular heart disease in India. And here, 10 years after his first procedure, He is receiving the Legion of Honor in France. He's being given this award by Alain Carpentier, the inventor of surgical bioprosthetic valves. And this is an example of what has been a very special heart team. So it has certainly been a journey over almost 2 decades to try to bring this technology forward, now to the point where it's being used systematically and frequently in essentially all patients with aortic stenosis, with many more interesting studies to come in the future, including asymptomatic severe aortic stenosis and even moderate aortic stenosis. So I hope that we'll have a chance to share these data and share experiences with our colleagues in India and in Asia. And I hope that we can work together collaboratively on new technology and on exciting new clinical trials in the future. Thank you very much.
Thank you, Marty. That was a wonderful overview. You sort of covered the range of topics, and I'm sure we could spend an hour discussing each of the issues. And there's a lot of things that are more relevant in India. It's generally a younger population. The etiologies are different than what we typically see in the U.S. But this issue of not just saying, it's a class effect, and we maybe need to look at different devices and different anatomies is an interesting question. I know we don't have a lot of time. I wonder, the only other person that has as much experience and has been at the beginning of the field is Eberhard. And he always has interesting perspectives. Eberhard, do you want to make a quick comment on your experience over the last 15 plus years?
Thank you, Sushil, and thank you, TCT India. It's a great pleasure and honor to be part of this exciting meeting. And I have to say, I know our mentor and supporter, Marty Leon, for many, many, many years. And I mean, I've seen many, and heard many low-risk presentations. But, because now it's not a secret anymore. He's in the age group of 65 to 75. And, he's still working hard on bringing us the up-to-date information. And I'm always stunned when I see his slides. I'm always learning. After so many years of a common pathway, his perspective, his evaluation, his analyses, it's just the brain that works regardless of whether he's 40 years, 30 years, 40 years, 50, 70, probably 90 years. So we will still hear something from Marty Leon about what he thinks about TAVR, or then maybe more importantly for mitral valve. So Marty, thank you very, very much. I've again learned something. I agree full-heartedly on your perspective. Particularly now it becomes when you talk about the age group that's a little bit lower than ours, looking into TAVR, I totally agree, nothing to add. And I just wanted to thank you for really giving this community such an immense and incredible insight into your working brain and into your perspective on these things. Thank you, Marty. I can't hug you, but I wish I could. Hopefully this damn virus is going to go someplace, but take my hugs and working for us. Sorry, she was a little bit more personal than
Wonderful. No, I think it's audience members to look at those slides and talk about all of the thoughts and limitations. And I think as the field moves forward, and especially as it grows in India, it's not the wonderful data, but it's the concerns that are relevant to make sure that you move the field forward in a thoughtful manner, and you look at it for the concerns that are relevant in India. And age is different. In the US, 75